many of you go to an annual or, you know, at least once a quarter doctor's visit, like once a decade doctor's visit and do your prevention doctor, you know, yes, you go do prevention doctor visits, right? The point of that is to hopefully get ahead of something that might potentially happen that would, you know, hurt you or in your life or whatever, create problems for you. So you go and get ahead of it, right? We also call that upstream approach, right? If you are at a river and people are drowning and you're like, hey, why are they falling into the river? And like, why are they drowning? Like, we should go up and stop them from falling into the river, right? That's the idea of the upstream approach. There's two factors to prevention, and one is risk factors, which you said, and the other is protective measures, which is when you put things in place to protect people who are at risk. So you have protective measures and you have risk factors. And today we're going to talk about protective measures and risk factors. Oh, that didn't transform. Okay. Sorry. The ideas at the Nichols Center are we do prevention and then we also do intervention, right? So if we see that you're drowning in the river, we're going to like stop and go, okay, well we need to get you some help. We might not have the treatment measures here, but we're going to refer you out and partner you with treatment. But we're going to also figure out how you ended up in the river in the first place, and we're going to go up and try to work with our community to put in prevention measures. And that's the point of C3R. C3R is to talk about the different interventions that are happening within a community, and then also what are the prevention measures that a community could do to get ahead of the problem. Prevention is very hard to track because you don't know you've prevented it until like 25 years later that you're like, hey, you know, our community doesn't really suffer with this, and we really thought it was going to suffer with this. And guess what? We don't really have that problem. We're not going to notice that until you're much further down the road. And so it's really hard to know as a community how healthy your community is until you get into it and you start applying these different prevention measures and then you start paying attention. They say, there's old, I think it's Chinese proverb, that the best time to plant a tree is 20 years ago. The second best time to plant a tree is right now. And so when it comes to prevention, the best time to put prevention measures in are 20 years ago. Because if you had done something good 20 years ago, you wouldn't be having the problem you have today. However, the second best time is right now. And so if you're not a part of a C3R, your community doesn't have a C3R in it, we should be building that right now. Because we're going to be addressing what are the interventions your community is doing, where are there gaps in these interventions, and how can we go upstream and put in these educational awareness and different strategies to prevent the issue. step to this fifth model is to do an assessment. Anytime you're building a program, you need to know where you're at, what you're starting with, and really, what you want to do. So you do an assessment. And at the Nichols Center through C3R, what we do is we look at the community and we do a community assessment. Where is the community at, right? What are some of the data points? What are some of the issues this community is facing? And how can we pull this community together to really understand where they're at and what are they dealing with, right? Every community is different. Cobb County is a very different community than Douglas County. It's very different than Paulding County. And then if you go out to Coweta or Carroll or Cherokee, you're going to have different organic supports, different interventions going on, different cultural beliefs, different demographics, different key issues. Some communities have a lot of services, but those services might not be working as well together. They might not have a lot of communication between those services. Some communities don't have a lot of services. They're in what we call a desert, right? Food desert or resource desert, where they don't have the supports because they haven't been grown organically within that community. And you need to, as a program, when you're designing a program, you need to do an assessment of what strengths and what opportunities does the community really have? Where are the gaps in the services? And then you need to understand capacity. So the second step is to understand capacity, and that is the resources they have and the readiness they have to activate those resources, right? Because you can have the greatest idea in the world, but if a community is not ready to take on that challenge, you are going to be spending a lot of energy trying to just simply convince them to come to the table. In some communities we've found they have a really, really great proactive law enforcement, right? Their law enforcement is ready to talk about crisis. And in some communities, their law enforcement, they're not ready. They're dealing with completely different problems. And then some communities, their fire department, like here in Douglas, we have an excellent, amazing fire department. They are plugged in. They want all the programs. They want to do all the things. Because internally in their system, they have champions that care deeply and have compassion for these issues. But then in some communities, their fire department, they're dealing with completely different concerns or problems, right? And so they're stuck. They're stuck dealing with other things. And so they don't have the bandwidth. And that's not necessarily something that means your program's not going to work. It just means that you need to understand, do they have resources? And are they ready for the change? Is that part of their capacity? All right, then we move on to planning. What's your plan? I have learned through working in nonprofits for 12, 13 years, it takes about a year to build a really solid plan. It takes about a year to put something together and actually understand what you're dealing with. And it takes about 3 years for any program to really get formed. And it takes about 7 before it's fully sustainable and thriving. And that principle is actually a principle that can be applied to business and can even be applied to gardening. It's true. Gardens take the same. It takes a year to plant it, 3 years for you to see stuff start to come together and grow, and 7 before you really have a mature garden. So think about it on those terms. If you started a program 6 months ago and you're like, why is no one attending? Why is this struggle? It's going to take you some time. Give yourself that time and put that time, build that time into your planning. All right, then we go into implementation. And this is where that 1 year, 3 years, 7 years is going to come into play. That first year that you're implementing into that third year, it's going to take a minute. But pay attention. And for C3R, the way we implement that is we start inviting key stakeholders to come to the table. And we host listening sessions, we host discussions, we host educational formats, and then we show up at different community events, right? Because we're there to understand and to learn and to listen. And then as you move in, now you want to evaluate the process. Today we're going to do some surveys. That's part of our evaluation process. You want to see and adjust your programming. And then we move into sustainability and cultural competence. And this is an important part of the puzzle, because if you're talking time, right? It's those long, like drawing it up for 7 years is really what you're gonna have to think about. So how do we make it sustainable organically within a community? All right, that's the fifth model. So in the last 4 years, I can't believe it's been that long, Stephen. Great, 4 years. The last 4 years, we started this in Cobb and Douglas, and then that's the blue dot. And then last year, we expanded by creating and starting to identify key partners in the surrounding communities, right? So that's the red circles. And then this year, we are building awareness and starting a pre-planning phase in the yellow circles. Now, how do we do that? How do we start identifying communities that are ready for crisis response, education, prevention, and training? How would you start?
Networking.
Networking, okay. Meeting people. What else? Assessing. Paying attention to the data, watching the trends, where's the need? What else?
Allocation of funds.
Funding? Sure. Now we're a state prevention provider, so thanks to our wonderful friends at DPHCD, we have a little bit of money to do some good things. Really good things. And we make that little bit of money go a long way. Because education's easy. It's so easy to share. Just by live streaming, we're sharing with a whole other country on the other side of the world. So networking, assessing, allocating, being a good steward of what you have. What else? There's a one key element that we need in each one of these communities. One key element. Well, you have to have ready. Yes, the community has to be ready.
How do you get out in the community and talk to the people?
Gotta talk to the people.
People that do the work.
Yeah.
People that do the work. You're really, really close.
The champion.
You need a champion. In every community, you need a champion. Everybody, I'd like to introduce you to Phyllis Calloway. Phyllis Calloway is our champion in Cobb County. In every community that we have a strong presence, we have a champion. And that's not always a person, sometimes that's an organization. In Douglas County is our fire department. Our fire department is our champion. Chief Farmer, Director Harley, our 911 director, is our champion. She is an incredible powerhouse for good. In every community, you need a champion. And if you have somebody who's going to champion because they passionately believe about this cause. In the back of the room, we have Ms. Sheree Ralston. She is a champion for DHD. She's a DHD champion. She will go anywhere and talk to anyone. And before all of this, Stephen George, she was a champion. You need a champion. Your community, you need to find that one single most important person that believes about it almost more than you do. And you need to equip them and get behind them and rally behind them. Because they will carry the torch. In Uganda, I have 2 champions that are continuing the work. And they'll blow my phone up, Miss Tara, we need this, Miss Tara, we got this, Miss Tara, what about this? And that's what you need. You need people who are gonna go before you and stand in those moments and spaces and advocate and be prepared for the crisis. So, who are our champions? Well, in the yellow dots are film studios. Film studios have a great need for mental health intervention, great need for crisis support. In the red dots, our co-responder units or alternative response units. And in the blue dots are our friends, people we've gotten a chance to network and build with. A lot of box of Narcan when you leave today if you give that paper survey to Miss Linda sitting right there in that chair. If you already have Narcan and you're like, you know what, I don't need another box, so I would like that lockbox, you could also get a lockbox. Okay, next slide. We having fun yet? Yes. Cultural competencies. Remember we talked about that, how we have to assess, we have to adjust, we have to look at what a community needs, we have to assess who are our champions, but then we gotta speak their language. We gotta be culturally competent to make mental health sexy. We can't come in and say, you know, well, we're just gonna talk like from a doctor perspective and you're ill and at the DSM. No, you have to actually make it feel applicable to the population that you are serving. So we reformat and rebrand mental health education and information to make it look like it belongs within that population we're serving. So we're talking to a church, it's going to look like it belongs at a church. If we're talking to film and entertainment, the PowerPoint slides and everything are going to look like film and entertainment information. How many of you got your little goodie bags today? In your handouts, in your goodie bags, you're going to see different designs in your bags. This was really probably one of the best ideas I ever came up with. How many of you have a prevention pin in your bag? Little magnetic pin. I got mine on today, resilient response. Tell me, what culture do you think resilient response applies to? What industry is resilient response applied to? First responders, emergency and public safety. a metal door, like a bathroom stall door. And the posters slide right in, and each pin, each campaign has its own poster. So we have one for every month of the year. And communities can very easily disseminate information on the refrigerators in the break room and on the bathroom stalls on mental health education. And it's simple. Imagine you're crying in the bathroom because you don't know where to go. You might be at a gas station, you might be at a church, you might be at a police department, I don't know. You're in a tough spot and you just need someone to talk to you. And you don't know about 988. 988 is everywhere, but for some reason you still don't know about it. But it's on here. You learn about the Nichols Center. You learn about people who actually care, people who would take 8 minutes for you. And you realize, actually, if it only takes 8 minutes to have hope, I could give myself that 8 minutes, right? Friends don't share. If somebody's sharing something that's gonna harm you, like a pill, that's not your friend. That is not your friend. Friends don't share drugs. You gotta recognize that. And the purple umbrella, who do you trust to hold your umbrella? Who do you trust to be there for you? Right? These are just simple ways to communicate in your community the importance of mental health and make it attractive. It doesn't have to look stigmatizing. So these are some of the wonderful programs that have come out of our C3R meetings, our C3R discussions, finding organic ways, to the next slide please, to communicate within communities. Handouts, educational materials, pins. What's that pin about? What's cute? That purple, what is that, an umbrella? And now you have a reason to talk to them about suicide prevention. And you're a suicide advocate.
Right.
So of course you're gonna talk to them about suicide prevention. Right? And it doesn't look like, oh my God, that's a crazy lady, what happened to her? You just have to take time to care. You have to take time to implement. So, we've developed and devised an idea called Race to Resiliency. How many of you have seen The Amazing Race? You like races? This came out of a movie. Has anybody seen the movie Arthur the King? About the dog? Oh, if you haven't seen it, you have to watch this movie. It's amazing. Arthur the King, epic movie. Epic. You should watch it. A lot of times, this is a story, very quick plot. I won't run the story for you. You should totally watch it. It's life-changing. So this amazing extreme racing team, they're in a race of their life. Everybody's racing for a very specific personal reason. And they keep having this dog that shows up along this extreme race. And when I say extreme, like people could die. Totally. Like they're going across the cliffs and, zip lining and carrying bikes and mudslides and almost, people could die here, right? This extreme race in, I think, the Dominican Republic or something like that. And this dog keeps showing up every day of their race. And the dog's following them. And they're like, what the heck is this dog? And at some point in this race, they have to choose between winning the race and saving the life of this dog that's been following them. And I was watching this movie, and it just occurred to me, this is how our communities work. We're all on a race for our own personal reasons. But at some point, we got to decide whether we're going to stop and help that person in crisis who's been there the whole time. And that person we could deeply care about. But that's the amazing race of life. And if we took time to design a race for communities might actually want to participate. Because each one of us has personal reasons why we're in this room, right? How many of you came here because you know someone that's been affected by mental health, suicide, substance use, or overdose? Maybe that's a personal person in your personal life, or maybe that's just someone at work. The population, how many of you serve that population? What's the population you serve? Do you serve that population because it's easy?
No.
Do you serve that population because the paycheck's good?
No.
Because if you do, I need to know that job.
We're hiring.
Huh?
We're hiring.
I don't want that job. That job's scary. I would cry.
You can do it.
So, yeah. There's a personal reason you have to be here, and it's not because it's glamorous, and it's not because it's easy, and it's not because it comes with that high rolling paycheck. It's because you care deeply about it, and it brings meaningfulness to your life, and you can see the efforts of the work you're doing. And so that makes you a champion. Whether you're walking as a champion or not, that makes you a champion. So, we would like to have an invitation for you to race with us. Every community in the state of Georgia should be racing towards resilience. And the way you race towards resilience is we've designed an incentive structure. An incentive, a collection of educational information and action steps you could take within your community this is around the office.
All right.
Yeah. Well, no, I need it at the office so that they'll listen to me. So, we're going to have a race to resiliency belt for the most resilient community. Between now and our fall summit, when is our fall summit? We don't have a date on that, we usually have it in September. Do we have a date on that? Between now and September.
September 9th.
Huh?
September 9th.
That was last year's, it was
Okay.
September 9th, it's gonna probably be around that time. We are going to have a community, we're gonna be tracking communities that are going to stand up resilient initiatives across their community and race for this belt. Now it's not gonna be this exact belt, because this is a half-baked idea belt. But we're gonna have an actual race to resiliency belt for the community that adopts the most resilient efforts for crisis response. So, if you don't, how many of your communities have a C3R? Who's here from Douglas? Okay, who's here from Cobb? Who's not here from Douglas or Cobb? What's your county? What's your county? Gilmer, what's your county? All right, you three do not have a C3R, but you could. Douglas County does not have posters in bathrooms. Cobb County does not have posters in bathrooms. Cobb County has a sandwich board. They have two of our sandwich boards, two different parts of the community. Douglas has one sandwich board up at the MOUD facility, the methadone clinic. Cobb has one at the at Harbor Springs and one at Powder Springs Police Department. But we've done several events at Cobb County for trainings. I just did one for their CLIA. I saw some of our folks from Powder Springs at CLIA. Powder Springs has been setting up a peer team based out of crisis rescue briefings that we've been doing for the last, what, year, 2 years? 1 year, 2 years?
It's about 13, 14 months.
13, 14 months. So they've got to jump on you folks. But Carroll County, I know Carroll County has a lot, I've done some assessments on Carroll County, and they got a lot of readiness, and they got a lot of resources. I don't know much about Gilmore County, but I know that lady in the back's a champion. Fulton County, Fulton County's got a lot. So you gotta think about it. You gotta think about how could you take the strategic prevention framework and in your community, in your city, in your county, in your job, how could you join this race? Are you a champion from now on? Are you interested? If you're interested, before the day's over, I want you to see Christian. She's going to collect the names of all of the individuals that want packages relating to resilient response or race to resiliency. And we're going to put these packages together, and we're going to develop a distribution network of this educational materials across the state of Georgia. Sound fun? It's going to be great. All right, guys, where are we at on time? It's 10 o'clock. Oh, look, see, here's some of the amazing stuff. This year, we're rolling out a resilient response. That's our first responder, public safety, professional handbook. It's going to be amazing. Right, Christian?
It is.
It's going to be amazing. We're actually going to be launching that in Florida this year. Christian lives in Pensacola, so there's going to be a Pensacola C3R before too long. Wait and see. Yes. All right. And if you're here from Uganda, we can bring this to Uganda. We already have started in Uganda. So, all right, folks. We're going to take a quick 5-minute break while we transition to the MIH slides. We're going to get into mobile integrated health and what that is and what that means. All right? Sounds good. 5 minutes. Fill up your coffee, stretch. How are we doing? Oh, I forgot to tell them about the app. How many of you have the Nickel Center app? That's another way. Download Nickel Center app. How many of you have gone on the website and become a member? Who registered? Straight out of the store? That's a good idea. Straight out of the store.
When I tell you, it was the closest place between all of Florida, all of Alabama, and all of Florida. Really? Because they were packed out, like there was, like literally, if I would have taken it here, I would have been able to.
Yes. I had a question for you. So do we, so
I was like,
so you said it's rings.
So, yeah. So
This lady right here, Miss Christian.
Yes. Hi.
Aziza, I'm with
Oh,
Douglas
nice-
County
nice
Senior
to
Services.
meet you.
Nice to meet you. So I want to know how we can get some of the posters for our senior center.
Oh,
bathrooms.
yes, yes. Let me get your information.
I have my card. Is it?
Yeah,
I
yeah, that'd be
just got
great.
that. Okay, yeah.
And then
But
let's
even-
make sure she's coming to the C3R meeting.
yes.
The first Wednesday of every month in Douglas County. We have a virtual and in person.
And I even thought, I know you said Fulton County has, well, I actually live in Fulton County. I work here, but I live in Fairburn. And I was just thinking about the one for the school bathrooms for the dog share, you know, stuff like that. You got kids bringing things to school from home, and they're sharing things with people. So, yeah.
I'll jump into it. Thank you. You're welcome.
Okay.
Doing great. Outside my element of safety. I'm outside my element of safety. Yes, you can. I know. And I was like, wait. I just asked about it.
Thank you so much.
You're welcome. I tried to do it without, like, I was like, I'm gonna try something. Yeah, I did that. The whole process. And then they came back to me and they said, you know, we need the number, because they guess they give you a number. I was like, perfect, man. And
Which one up?
I was like, oh, I don't have that. So will you have to like yeah, it's another $200. You have to pay $200.
That you're following along. So you know it's like.
Yeah, yeah. 'Cause at first I wasn't. I was like, oh, I need to know what's happening next on here.
So smart.
Well, I mean, the only thing I got was the first time. So it shows that it's still like pending, but I've not submitted the stuff that I saw. There was one day I was trying to do it, and then
Yeah, because I was like, trying to see what happens. Yeah, like, see if it's they caught it. They were like, oh, yeah. Because it takes a long time for them to get the paperwork. Like, because I submitted the paperwork back in October. They didn't get back to me until
See, I want to
January.
find a way to.
So that's why I was like, I'm gonna go ahead and do this because I know the process is gonna take long. But at least though, they did tell me everything's in the system, so I don't have to go back through anything. I just need to give them the number. And then, yeah, and then one lady emailed me back and said I may not have to pay for it again if I do it. I guess because she was like, it's a time period, so it's within a certain time period. Then she said, and I
Exactly.
that would be great. So yeah, so I'm just waiting for that.
almost there.
Talking about the search?
Yeah.
Yeah.
Are you gonna take it, Melissa?
You got it.
Second time.
Have you been
So we're gonna
practice?
Huh? I have. It's been hard since I've been here to like really practice, but tomorrow, Sunday, I'm dedicated to study because I take it early. I have to be there at 7:30. So. Okay, so I took it in the afternoon, the last one. So then I was like, I'm gonna go for morning this time.
As always.
You know, maybe early morning and get me focused. So, and then I'm gonna stay the night. Like, I'm staying at a hotel that's like right beside the Where do you do it? I have to go I do that one,
It goes into it.
yeah, it qualifies me to be.
It has residency.
Yeah, to do like teleconference. That's how
So
it
do you work
works.
for Florida Beach?
You have to do what you need to do with her. She did. I don't know how she became qualified for it. She just, I sent her the link and she figured it out. Yeah.
Look, don't you have to do like extra courses?
Yeah, first, yeah, because Florida, the exam that they have is a little bit more extensive because it's very case study based. So they have some like extra additional, but I think she already had certain certifications that qualified her. So we get also to because she was a registered supervisor, that also opens up doors to because I eventually want to be able to. My goal is to be
How much are they gonna get?
Like,
No.
Out there who are actually like registered on these things.
all 50 streets.
that would be crazy.
Yeah, there's no way.
I doubt it.
That's crazy, you know. It would be
I-
nice.
When the legislature actually goes into where there's reciprocity for greater amount. Like during COVID, it was a lot easier. There were a lot of states that, like Texas and Georgia and a bunch of other states were working together, and then they cut it off.
Yeah. Yeah, that would be nice. It's actually not as difficult to be certified in different states as you might think it is. Because the longer that you're in it, like getting like in the certifications of like those things like do open up doors. And especially too like for the 2 years post that, yeah, 3 years I guess in Georgia. And wherever she's certified, you can see clients because she has supervision in those places.
All right, Chris, so we pull up the MIU
Yes, I can.
slides. We're gonna go through mobile integrated health.
Yeah. Where's my circle? I need to read. No, that's not it. That's not it.
No. I'm a lieutenant. I do not. My son's 3 years.
All right. Let's get into mobile integrated health. We're gonna have my two friends in the back wave. If I pull them up here, they're going to quit. show up for people like me on my worst day ever. And that's a pretty amazing thing if you think about it. That you, in all the world, could live almost anywhere, but you get to live here, where there's someone like this beautiful lady here, or someone like this gentleman, or this lady here, would show up, or these two in the back, would show up for you on your worst day ever. And maybe it's not actually your worst day, but it feels like your worst day ever. It could. How many of you have survived 100% of your bad days? Do you remember those bad days? You probably remember those bad days a lot faster than you remember the good days, because guilt and pain live in the same part as pleasure of the brain. But it feels good to feel bad, and so we think of the bad things much easier, right? And so if you get to live in a community where wonderful, incredible people would stand in the gap for you, that's amazing. But usually when you want one of those wonderful people to show up for you, you're going to call 911. Or you can call 98. That's a newer engagement method in the last, 3 years? 98's been around 3 years, I believe. Where's Sheree? Sheree said 3 years. It's been rolling out. 98 is the crisis line similar to 911. And then new programs and teams have been standing up across the nation called alternative response or co-response, and that's when you have a dynamic of two different disciplines showing up for you on your worst day ever. So two different types of providers. Co-response usually involves law enforcement. Alternative response could be any number of individuals within public safety and another form of a professional. So that could be LPC, LCSW, certified peer specialist, with another professional in public safety. And they're showing up for you some tools to help, understand that they have to be in that survival mode, and that is their state of constant existence. And that's why I think resilient response is such an important model, because first responders, law enforcement, public safety, if they stay too long in that survival mode and they don't understand they can come up for air and they can feel safe and they can feel love and they can feel connection, they're going to end up, becoming a person in crisis. And that happens for law enforcement. The statistics are not great. Well, let's get back to mobile integrated health and alternative response. So we found in Douglas County, through having some of these conversations with C3R and watching what our friends in Cobb County and Clayton County were doing, we realized we really needed a co-response and alternative response model. And because of our community assessment and our readiness to apply new strategies, we found our champions at the fire department, and the fire department said we really want an alternative response model. Now, we couldn't do a co-response model in the fire department because we didn't have that law enforcement piece. The reason, why do you need a law enforcement for crisis response? Safety. When a clinician shows up and signs that document, what's that document called?
1013.
1013. Everybody know about a 1013? Anybody confused about a 1013? When a clinician like me shows up and I realize that that person's in survival mode and they need a 1013, I'm actually writing an order to apprehend their rights. They are an American citizen. They have a right to their crazy. Did you know you have a right to be crazy in America? You have a right to be crazy. You can be cray-cray all day long. You can be on the side of the road if you want. You are a free citizen in America. You are free to act that way if you wish. As long as you do not break any laws or impede anyone else's rights and liberties, you have the freedom to be nuts. It is okay. We're in America. You can say cray-cray. You can say cray-cray. I'm cray-cray sometimes. I have a right to be. It's okay. Me and my chickens, we are okay. We have this freedom. Right? It's amazing. Not that long ago, we would institutionalize people for being cray-cray. Now we just let them dance in the streets. They want to dance in the streets. They're okay. A 1013 is not about getting them better. A 1013 is about keeping them from harming themselves or someone else. That's it. It's not about making them better. They have a right to choose their own healing journey. If they do not want to choose to get better, they cannot choose to get better because their life as they are living it feels safer than the process of healing. Whatever they have that they're having to face, their life in their dysfunction, it looks dysfunctional to us, but it feels safer to them than actual healing process. So sometimes that dysfunction that feels normal, that chaos that feels normal, is better for them than the actual process of trying to heal their life. Trauma, pain, suffering, memories, guilt, whatever. They're not ready, they don't have that bandwidth. Grit is a muscle, their muscle is exhausted. Compassion is a muscle, their muscle is tired. Their given hands busted, folks. And they don't have it to put it together. So we're not going to judge them in that. But we are going to try to keep them on this side of the afterlife. And that is a harm reduction measure. So in our mobile integrated health program, we have a team of 3. Technically we have a team of 4 because we have a wonderful chief. He's not on the slide. But we have an incredible chief, Chief Dickens. I'm the clinical supervisor. Gina is our community paramedic. Wave, Gina. And then Sierra is our incredible case manager. Wave, Sierra. Talk to Gina and Sierra. They do an incredible job. Their job is to identify when people are at risk within the community and then step in and apply those social support services to prevent further crisis. All right, next slide. So, our core objectives in mobile integrated health are patient-centered. Why patient-centered? So it's people first. People first. Trauma-informed is about the person. Then proactive interventions. Proactive. Don't wait till it's going to really fall apart. Be proactive. And educate and empower. Our goal is to educate and empower individuals in their healthcare needs. Next slide. What kind of supports do our individuals in our community that are at pre-crisis stage, what kind of supports do they need? A person. Sometimes that's really what they need, is they just need a person. A helping hand. They're dealing with loneliness, they're dealing with medical issues, they're dealing with grief, with loss, they're dealing with, sometimes with chronic issues, diabetes, hypertension. But a lot of these individuals just don't have people in their lives that care about them. Or the people that they do have in their lives are not physically capable of caring for them, right? Like they might have really lovely, wonderful relationships, but the people aren't strong enough to lift them out of the floor. Do you know how hard it is to lift somebody out of the floor? It's not easy. And the older you get, the harder it is. Right? How many of you have to call to schedule a doctor's appointment and you call one number and it reroutes you to another number and then you have to listen to a list of 12 doctors and then you hope you click the right number in order to get to the doctor, but then they have 3 different sites and then you gotta click another number because you're not sure if they're at Dunwoody office or Alpharetta office or Gwinnett office. You're not even really sure where Gwinnett might be. You just heard about it. And then you gotta click and then you gotta listen to 4 other numbers because one of them's for a nurse hotline, and then one of them's for to leave an appointment, and then one of them's for, I don't know who that one's for, right? How many of you, that's you? This is why I just don't go to the doctor, and that's not a good result. Gina will take care of me if I fall out. It'll be good, right? Because especially if you're dyslexic, then it's really bad. Oh my God. Was that number 5 or number 3? I don't remember. I listen to all of them.
You gotta restart all over again.
Now I'm lost. I gotta start all over again. It's exhausting. And I'm a pretty highly functional person. And you ask why? Why what? Questions. May you ask questions? Yes. Yes, ask questions, please. Yes. So navigating insurance, navigating scheduling, navigating these systems that are supposed to care about us. And yet, we're the one with the dial code that does not feel cared about. Don't feel cared about. All right, food insecurities, housing, these are all issues that mobile integrated health has taken a proactive approach to try to impact. All right, next one. How are we going to impact them? How are we going to impact them? Well, we started with a wonderful case manager. We said, all right, case manager, we're going to let you spend 3 to 6 months just to kind of get to know the community and get to know the different resources available and to start going out and talking to these folks and really understanding what their problem is. Have the conversation. And she is great because she's so excited to get in and solve the problem. Figure out, okay, this person, they need this, they need that, they need this application here and that application there, this, that, navigate this. It's like a puzzle. Solve the puzzle. And that really helps us understand how we're going to help these individuals maneuver through a system, because every person's system is different, because every person's problems are different. So you really have to be very said, okay, now we're going to address where we document, right? Because the first thing you're going to want to do is to develop care plans, and care plans are what we call longitudinal documentation. There's documentation over time. But what you might not know is law enforcement, first responders, and public safety, they do not do longitudinal documentation. This was a very big, like, I had never even thought of that. How do you not do longitudinal documentation? I've only ever done longitudinal documentation. They do incident-based response. Incident-based response is one tiny note system, and it might not feel tiny at the time because it's a long document they have to go through, and then it's done. They're never gonna go back and retouch that unless it goes into court. They just move to the next, and move to the next, and move to the next for thousands upon thousands of different incidents. But once that incident is done, they're on to the next. And 911 is even more rapid because the minute they hang up, they're getting another call. The minute they hang up, they're getting another call. On average, how many calls you guys run about a night?
Oof, anywhere from 10 to 15.
10 to 15 calls. Every night, sometimes more. You might have a slow night, but really, you're gonna run the community's been growing. And we were not prepared as a community with a plethora of resources to respond to that population growth. When you show up as a first responder or a co-response or even an alternative response, and the person you're talking to believes deeply in dark magic or witchcraft or some other form of religion, and you're speaking from a medical standpoint, they're not going to always understand or receive what you have to say. Because they're coming from a very different cultural background, and that information is important for you to know. That's important for you to know. Because they're not going to hear if you're coming from this high clinical, DSM model. If that person that you're talking to is coming from a different socioeconomic status, and you're showing up with, all your perfect whatever, and they're like, hey, I'm in active chaos in my life, and you're afraid to even walk in their house. Well, now you're alienating them. So these are all things that we had to be, as a community, we had to be aware of. We had to be aware that our community was highly diverse, not just in ethnicity, but in belief systems, in backgrounds, in traumas. There's diversity to trauma. If you're showing up as someone has sexual assault traumas, or child abuse traumas, or grief and loss, or suicide trauma, they're going to respond differently. And you have to have eyes to see that. Just like Gina had to be there to have eyes to see the medical issues, we had to have a program that was competent to see the diversity within our own population. Next slide. We also know that the demographics of our community, we were having an expanded elderly population. We did not have the resources, the housing, the supports, the doctor, we have the healthcare provider desert in Douglas County, the transportation desert in Douglas County. We did not have the natural resources to support this expanding elderly population. Next slide. So what did the data tell us? What were some of the 5 biggest issues that we thought, with a little bit of education, a little bit of trauma-informed responses we could make an influence on? The first one was falls. A lot of individuals fall, right? Falling is not fun, I don't care how old you are. The older you get, the harder it hurts and it's harder to come back from. But there are things you can do for fall prevention. You can strengthen your hands. You can do movements to increase your balance. You can pick up the rugs off your floor and get rid of them. You can give your animal, if you have a furry pet, my cat almost stripped me to the office the other day. You have a furry pet, you can pause for a second and let it get its zoomies out before you just start walking and not paying attention, because you could trip, right? Fall hazards, falling. Some of the others, the highest rates were self-harm and suicide. So we saw that we had an elderly population with medical dependence, chronic illness, and mental health. These were our 2 biggest data points for Douglas County. Next one. Some of the hospitalizations came from chronic physical illness that led to mental and emotional, right? Hypertension, diabetes, cardiovascular issues. If you're not drinking water, not eating protein, it makes sense that some of these things are happening for you. But if nobody's there to remind you to drink your water and take your medicine and go to your doctor and get up and move and go sit in the sunlight, if nobody's there to help you with that, it makes sense that you're not doing those things. How many of you struggle to drink water? Oh good, I'm in a good group, I'm not the one. I'll have coffee all day long. That's not the same. So, the reality is if you don't have people in your life to care about you and to connect with you, you can be dealing with some of these issues. Next slide.
Ooh.
Oh, this one didn't download correctly. engaging community partners. And that's where you come in. Different individuals within the community who can stand with us and be part of our team. Who can say, all right, this person has a strategic challenge and they really need a community. And 911 cannot be their community. 911 can be there if they are in active crisis. But 911 cannot be their social support across all those systems. So MIH is going to step in for a period of time, and we're going to engage them in a system of structural support across community through our community partners. So how can we engage them in public health services? How can we engage them in family connection services? How can we engage them in senior center services? Those are just 3 of our big champions. How can we set them up with food stamps and a WIC card, a WIC program? How can we, if it's a young person, sometimes we deal with young people with developmental disabilities, how can we plug them in with developmental disability services? DBHCD, can we do the now-comp waiver? What can we do to help this person navigate the social systems? Next slide. And then we worked across these 10 areas to begin plugging them in to resources. So now our team of 2 will go out, we'll do an assessment. Do I have a slide? Can we skip to the slide that has all the bars of the program? Keep going, keep going. Talk about this, this one right here.
Oh.
Back. All right, so we come into contact through 911 system or referral from the field. We begin assessing that person. Is that person going to be, they just need a couple of things. They have a good social support network. They're not totally alone in a loss. They really just need a short burst of support, and then they can manage again. They can stabilize. They are on our short track, 30 days usually. Come in, plug them in, follow up, make sure that the problem gets solved, and then they move on their way. Then we have the 3-month transitional, 3 to 6 months. They're transitioning through services. We're going to put some high-level services in place, but it's going to take time, right? They're going to need to get approved for some things. So we put them on that short transitional care path. That's about 3 to 6 months. Come in, do a full RAP plan, get them plugged into our community partners, put them on this 3 to 6 months, do 2 months of follow-up, make sure that everything we put in place sticks, and then they're golden. And then there's those chronic cases where those individuals do not have the ability, for whatever reason, to have that level of support in their life. And they're going to be with us for a long time. And that's okay, because we're here. At least they're not being dependent on 911, and at least they're not alone in a loss, and our team can handle that. And so we come in, and we know that these individuals might not have a great amount of resources to help them have this happily ever after experience, but we're going to be with them so that they have that dignity to hold them through those times. And that's what MIH does. We have in the last, I think, and I don't know if I put it on this slide because this is an older copy. Do you have the last slide that talks about MIH across last year? What's the last slide on this slide deck? Oh, no, it doesn't have it in there. All right, so in the last year, when we started, we had 147 identified high utilizers of 911 system. These would be people who are dependent on 911 for chronic care needs. And after the first 6 months of researching, doing the data, identifying who are our true patients, we ended up with 48 in 2025, 48 cases that we directly impacted on one of those 3 methods. We have seen from Director Harley's report, we have seen a decrease, I think it was a 4% decrease in 911 calls in 2025 just with that case management piece. Now, we saw a 1,000% increase in diverted calls to 988, which tells us that mental health needs to be our second pillar, our second program, right? In 2025, I believe Director Harley said we had somewhere around 350 suicides. I think it was like 335 or 338, something like that. And I will get that data. This is data we talk about at C3R. So in our C3R calls, having 911 as part of your C3R, if you're thinking in your community you're going to set up a C3R program, in C3R, having 911 at your table is very important because they're getting that raw data. They know the pulse of your community. So she is able to tell us what's happening in real time. And then leveraging your community partners within that program, within C3R to say, okay, where can we grow alternative response programs? Where can we grow prevention measures? Where can we engage different community response for crisis? Do you guys have any questions? Yes, ma'am.
If someone is having suicidal ideations because of a medication that a doctor has put them on, would they know it well enough to be able to communicate? I mean, they may say, I want to try to kill myself, or I just want to die, or whatever. Would that person know enough to know that maybe something their doctor just prescribed last week is now causing that? And would the person who respond know to try to get to find out if that's, is there any way to catch that information fast, I guess I'm asking?
Yeah, so actually that's a really great question. So the question, I don't know if you heard it, was if anybody has recently prescribed medication that's altered their mental state, right? And now they're experiencing suicidal ideation, would they be aware of that? Or would the people around them be aware of that to be able to communicate? And that is only as good as your care plan. That is only as good as your care plan and your cognitive ability in that moment. So the answer is not always. Not always is that person gonna know. Now, if they can remember, because remember they're in an altered state, but if they can remember, oh yeah, my doctor, they just changed my medicine. Oh yeah, if you have a caring, compassionate person in the home that is aware, a mom figure or somebody who's like taking care of you. Oh, I noticed you've been behaving differently. But I'll ask you the return question: how many, and not to pick on women, but how many women at least once a month are in an altered state? And are they ever aware of it? Not always. I mean, it's true, not always.
And your medication, if it's known, it should have it on there that it may increase or if people read all the
There you go.
information.
If people read, so when you go to the pharmacy, and this is one of the great interventions that have been coming out with opioids, right? If you go to the pharmacy, and you know that little box, it's not even a paper anymore, so you don't really get to see it. You like scroll in this little tiny box. Not this one where you're gonna put your card, this one over here. Now I'm not sure what this is over here. So you're like, do you accept counseling? What kind of counseling? Am I getting counseling now? Click yes, sign here, sign there, take my money. But that is
may not even have anything to do with suicidal ideations yet.
And every brain chemistry and every neurological process is different for everyone. Right? I thought they called it a cocktail tasting good.
I just wonder if it is.
One of the things that I find on the road, I always ask when I respond to somebody that's having a mental health issue, do you take any medicine? Like, ask specifically, or has your medicine recently changed? But a lot of times what I found is somebody will say, well, I was taking the medicine, it made me feel funny, and they don't realize they're not supposed to just quit cold turkey.
Yeah.
And that causes a lot of the issues that we see out there.
Yeah, and the same with substances, right? So self-medication. So a lot of times people will say, well, I'm taking medication, but what you don't know is that they're also self-medicating on top of that medication. And they're gonna tell you the medication that they're prescribed because that's safe to tell you that they're prescribed this medication. But what they haven't told you is this other vape thing, or this other smoke thing, or this other pill thing, or this other alcohol thing, or the gummy bear thing. They're not gonna tell you this other self-medication piece. And maybe it's because they don't wanna tell you because you're not a safe person, maybe it's they just don't remember, right? So, that's the other piece to this. A lot of times it's like, whether they eat or not, that changes your metabolic rate. But one of the greatest ways to impact anxiety is to eat breakfast. You can reduce anxiety astronomically by eating breakfast. It balances your hormone levels for the day.
Benzodiazepines. Yeah, let's go there. You know, you got the Ambien shuffle, and then you got all this other stuff, and I know a lady that got a DUI. Didn't drink a thing. I know another lady that went to Taco Bell, don't even remember going. It has an effect on you, just like the values of, what is it? Xanax? Older people forget to take it.
Absolutely.
And then they take it again.
Yeah.
And it's like your body, as you get older, I'm 73, just turned, these drugs, I don't take it, but they'll stay in your body longer.
They will. Your body doesn't metabolize them out.
Right.
And benzodiazepines specifically are very, very, very hard to detox from. They create a lot of physical pain in detoxing. Insomnia, pacing, like benzodiazepines are highly addictive and they alter your state very drastically. So, and they're commonly prescribed. Klonopin is commonly prescribed for anxiety, and it look, eyes moving. That's why you're able to create those images in your mind. Bilateral stimulation allows you to activate a neural network that is normally not available to you. Your active memory is about 2 feet. Your subconscious memory is 11 miles. You can activate the 11 miles through bilateral stimulation, which is why it allows you to go back into those memories to find the different puzzle pieces and put them together. What are flashbacks? Flashbacks is when your brain happens to stumble on a puzzle piece that fell under the couch. That's what a flashback is. Your brain's going, ooh, you have this unhealed memory. Now, cognitive behavioral therapy will teach you that if you have this unhealed memory, you should just recognize that you're triggered, use some coping strategies, and then tell yourself to not operate in a triggered state. And that kind of works a little bit. It helps you recognize that you're triggered and go, okay, I'm triggered right now, I'm dealing with this, be patient with me, I'm gonna get grounded, and then we're gonna but that doesn't actually put the puzzle piece away. EMDR, through the use of bilateral stimulation, either the eye bar, the light bar, or the tappers, can actually allow you to activate your neural network while you're processing and creating that trauma narrative so that you can find where that puzzle piece is and put it in the memory. Put it away. That's what EMDR actually does. And so that's why it's my favorite form of therapy. But you shouldn't do that if you don't also have that CBT, because if you leave and you realize emotionally that you've been carrying around these memories for so long, and you walk out the door, you might have a physical response to that putting away, and you're going to need some tools and skills to handle that when you walk out that door, right? Because you're going to have a visceral response. The body keeps the score. Think about it. When you go to, have anybody been to Mardi Gras? When you go to Mardi Gras, there's a visceral response at the end of Mardi Gras, right? That is what your brain looks like. That is what your brain looks like after trauma. When trauma happens to your body, you dump chemicals in your brain in order to survive. Fight, flight, freeze, or fawning is a chemical response. Oxytocin, neuroepinephrine, adrenaline, all of those are actual Mardi Gras explosions in the mind. If all of those things are in the mind, your brain has what we call reuptakes. Their job is to go in after Mardi Gras and clean the streets up. They're street sweepers. But if you're using a substance and that substance is destroying those reuptakes, like methamphetamine actually destroys the reuptakes in your brain, and that way you can feel the high longer. If your brain has been living in this constant state of trauma and this constant state of Mardi Gras and it does not have a chance to heal, your body is taking all of those chemicals and shoving them anywhere it can. And that's going to be in the soft tissues of your body. Your spinal column, your joints, right? Your soft tissues, your fat cells even. Sometimes when people lose a lot of weight, they actually will experience the signs of detox from their own depression because their body has kept that score, right? And if you're not doing these detoxes for your own physical responses to trauma, and you're carrying them around. And yes, you can CBT, you can recognize, hey, I'm triggered and this happened and da-da-da-da. That doesn't actually heal you. That doesn't actually detox you. At some point, it would be great if you weren't always triggered. At some point, it would be great if you learned what really is broken, or what is really hurt, or what is really upsetting you, and actually put that away. So that when things happen, you don't get triggered. Because you've handled it, you've dealt with it. You cannot not receive that. It cannot stumble on your puzzle pieces. Right? And that's the power of EMDR and other bottom-up healing processes. So when picking, and again, we're talking about It's gonna happen. Right? So when you have a medical response, you have to also have some other behavioral interventions, right? And that's what Steve and George is saying, is that you should also have these other interventions in your programs. Right? This is Circles Group. If you guys haven't heard of Circles Group, you should come by and talk to them about Circles Group. They address financial instability and financial insecurities, but they're also combining trauma-informed approaches into
and it can't be me.
Right. So if it's behavioral health, the CSB has case managers, Community Services Board, they are your case management system. Or the Nichols Center, we have, and Linda, go ahead and come on up if you would. Linda is our family advocate here at the Nichols Center, and they will support families we will support families, I wear many hats, we will support families walking through IEP and 504 planning for case management. We also have therapy interventions. You're gonna learn more about that today. But yes, that's a referral. If there's medical or 911 dependents, they're calling 911 an awful lot in order to manage the crisis. That's a MIH.
Sometimes it's just that they don't understand the system, or they don't understand what they need. That's what we need.
And now it's not that they're, where they haven't shared with me that they're calling 911, but it's just when I'm just asking, cause I will, like, are you taking care of yourself?
Yeah.
Are you going to the doctor? Do they have you on, well, I'm sure they have you on a treatment plan, but are you following it? And so that triggers me to think, like, they need someone, it would be helpful if they had someone to, remind them while they have other crises going on, that are you taking care of you?
So, you've said medical, crisis, that's perfect referral, right? Yes. Now, if you called me and said, Sarah, have you gone to the doctor regularly, and are you taking care of yourself, and are you drinking water? I would be an MIH referral based on that. So you have to ask, are you in crisis? That crisis piece, that's that other piece. Cause, I probably need my team to follow me around and check on whether I'm, taking care of myself too, because I think everybody in the room would probably also need that. But that piece of, they have this medical, that chronic care need, that chronic medical condition, lupus, or diabetes, or high blood pressure, or any of these things. If it's behavioral health, the CSB really is supposed to be that standing piece, that case management for mental health, behavioral health, psychiatric in our community. We do not have a psychiatrist. We can connect you to a psychiatrist, but we do not have a psychiatrist on our team.
Your teams?
No,
Are you
no,
saying that
at
the
MIH.
CSB doesn't have one anymore?
No, MIH does not have a psychiatrist. Mobile integrated health is chronic care needs, medical crisis.
Okay.
Behavioral health, psychiatry, CSB.
Okay. Now, then, do they be in a medical crisis? Like, I was thinking of this parent, and she's in crisis, because she is not a medical crisis, but she's in crisis, because she's just loaded all this other stuff on me. And like, I can get the help of the family with finding services, because I will ask you need someone to talk to? Let me send you someone based on your insurance. But the
start going on these medications at about 5 to 7 years old. And yes, does it do certain things? But yes. And then here's what happens. So we put them on the medication, then parents say, well, I'm not gonna give it to them on the weekends. I'm only gonna give it to them 5 days a week when they're in school, but I won't do it when they're home. So we're putting them on, taking them off, putting them on, taking them off, putting them on. Then they get a little bit older and then they can't sleep. And so then they can't sleep because they don't go to sleep on time. So then we put them on medication so that they can relax and go to sleep. So then they're taking medication so they're not too hyper and they're starting to sit in their chairs. And then they're doing this, and then you take medication so you can sleep. And then hits puberty. And we go, well, we gotta take them off at puberty because some of this medication interferes with puberty, and we gotta change the dosage, change this, and do this. And so we take them off. And what do we find at the last of middle school and high school is a lot of these youth start self-medicating because they're so used to trying to be in control. And can you imagine a little person at 5 years old who every single day comes home from school and their parents are looking at whatever the teacher might have written or however going. You weren't a good listener, you didn't stay in your seat, you didn't finish your homework, you didn't finish this, and here, what are you gonna do? I will tell you just from, I've been doing this for about 30 years, but also as a personal piece of this, I have a little grandson and he's 7 years old. He hears that every single day. And so he started saying to me when I picked him up from school, I tried to be a good listener. Man, I tried so hard to be a good listener. And I said, but were you kind? And he said, I'm trying to be kind. I was kinder than I was a good listener. And I said that that's an important thing. Did you talk to somebody that nobody else talked to in school, in your class? I did do that. I did. And the next day when he gets in my car, instead of saying, were you a good listener, he'll say, Gaga, I ate with someone at lunch that nobody wanted to eat by because no one likes it because they smell or because they make a mess. But me and my friend got up and went and ate with them. I said, then that's great. That's a point. That's a good thing. But they usually don't hear those kind of positives sometimes. It's always, were you out of your seat? Were you bothering others? Were you touching somebody all the time? Because he's touching you all the time. Or somebody. So sometimes we have to think, what are all the different pieces that we can put in place so some of these little people start to be able to figure out, how do I regulate myself? The other piece of that is all of these little people that go to school and go through life and have a disability or recognized with a disability also could be the child that has experienced a lot of trauma in their life. So where Tara was talking about, here we got the trauma and we're trying to mend the trauma. And then we come over here and we have a disability such as a significant learning disability or any other piece like that. How do you put all those pieces together again? Because you're going to compound people with disabilities, such as myself, if you have trauma, and you're going to try to sort through the disability, and then sort through the trauma, and then figure out what kind of person am I going to be. Because everything is going to play on each other. It's all going to come back and hit you. Because if you can't do it because of your trauma, my gosh, somebody's going to say, and you know yourself, you can't do it because you have a disability. All of us would like to say we don't. Right? We don't have a disability. I've been doing this 30 years. I'm not sure I've ever met anybody that doesn't have some sort of disability. Am I a good friend here? Yes. So one of the pieces I'll tell you about Amanda. Amanda and I have worked close side by side for a long time. I told her when we started working next to each other, I said, I need you to know that I have a significant learning disability. That means it affects math, reading, spelling. Now I can do 150,000 really good things, but there's probably 6 or 7 no. there's probably more than that I have to question. But it doesn't have to stop you from being successful in life. But I told her, if you sit close to me long enough, if you start to work with me close enough, you too will get my disability. She said, that can't be true. That can't be true. And I said, I'll show you. So I can write things, and the way I write it is not the way it is at the end of the day. But I can check it. But I can write it now in my language, and my gosh, she understands everything I say. So 20 years later, being this close, I can write it, she understands it, she's got it. But that takes a lot of practice, because when you're a little person, you don't feel very successful. So what happens then if I grow up and I don't actually know all of that? Because all the things that we say to people sometimes are very effective. And then let's put that person as an aging person. And all of a sudden we're saying, you have to manage everything.
Tag me in.
You have to manage everything.
It has been wonderful working with Linda. It's a whole different world, and she's right. I walk in here one way, I'm different now, and I know it. And I'm glad for it, because it has been wonderful learning how to navigate. My table out front is the lime green one, and everything on the table is about resilience. And the reason why I'm on resilience, two things. One, I feel like it's important for a community to grow resilient, but two, if we don't learn how to do it, we don't just cripple my babies, we cripple my seniors, because they haven't developed it. And you know, if you have one of our wonderful millennials, I have one at 25, if you don't teach them resilience, they are completely disabled in a different way. And we don't always recognize it, because we don't see it, because they're walking, talking, they're learning. But they're not able to problem solve. And they can't deal with anything, because we've taken a really good job, and especially my generation, we took it on ourselves to make sure my child's not gonna go through all that stuff I went through. No way, no how. And in doing so, we have become so protective that we have made them unable to be able, as my husband would say, to pick up a shoe and kill the mud. Scream, which means I'm not resilient when it comes to love. And I'm okay with that, because I haven't tried. But I should be able to say there's a fly swatter, pick up the fly swatter, pick the bug. Or pick up the fly swatter, and there's the bug outside, which I will do. But get rid of the bug, that's resilience. So resilience is a think of a way to figure it out and use the way that you know to do it. My table is full of things on resilience, and I did just bring a resilient for kids. I love my kids, aces. But there's also things out there for how to become a resilient first responder. And I know we have some here that I would love you to take that with you on first responders. I have how to be a resilient person who works with the faith-based community, because I believe in God and therapy. I do. But everyone doesn't, and sometimes our pastors and leaders don't. But we've got to teach them that you are building resilience when you teach them how to pray hard, love hard, give hard, and then be able to say, I need help hard. So we need to teach resilience even in our faith base. And then resilience, when you talk about early childhood, like you said, when they're smaller, that's a different thing. You've got a different capacity to be resilient, but you've got to nurture that and teach that and help them to grow in that so that they become strong, resilient adults. And then when we had faith-based, we had early childhood, we had first responders. We even got resiliency in a nonprofit. Oh my gosh, what do you want to do if you want to save the whole world? That's what a nonprofit, pretty much where you are if you're a nonprofit. That's what save the whole world. It's a little thing. I can do it. But what happens when every day in our first responders, especially at 911, where in every minute you're adding another crisis, another trauma, another, I'm solving another problem, another problem, another problem. It's hard to stay resilient when it's happening, but you have to learn how to become resilient when you know the next problem is probably in 10 minutes. So I want you all to come out, go out to my table and take whatever you need. If you need any of this type of stuff and you want to hand it out somewhere or you want to share it with the people in your organization, please just contact me. My name is Amanda Bryant. I'm at Douglas Core. My number is 404-545-3556. I don't expect you to remember it, but it's I love J-Lo. I don't know why. 40 I love J-Lo. There you go. I didn't ask for it. I even know I said that was too cute. That's so funny. Okay, but it's Jesus the Lord, not Jennifer Lopez. But all right, call me and say that I need some more of the stuff. Grab one from my table now so that we can all get one. But if you need some more, I'd be more than willing to provide it for you. I will even put your logo on it. I do not need to take credit for it. I just want you to have it. And that's kind of how Douglas Court is. We don't really care about taking credit for it. If you can get the resource and we can help you get the resource, put your logo on it, let it be yours, baby. But get it out in the community so that we can build a resilient community. Douglas County is going to be a resilient community. We're going to go through it all and still be standing. And that's the way we got to go. I'm back. Happy.
One of the pieces that when I'm working with mobile integrated health and family advocacy and individuals with disabilities is there are a lot of families who their children with disabilities have grown up but are still at home. And so we have a whole population of parents that have aging adults with disabilities and only a small amount of waivers that they can sign up for. When you sign up for a waiver at DBHDD and developmental disabilities, you can have a wait list of 5 to 7 years. That's how long the wait list is to get a waiver. Unless you can figure out a connection, how to maneuver and go in and out and try to figure out a system. Is that not true? It could be 7 years to be on a wait list. Now, I'm not sure where the wait list is and how it exists, but sometimes that's a fact. So what happens with your aging community when they are still at home with their adults with disabilities, wondering what they should do? I work with a whole population of a lot of people with disabilities. And one of the pieces that I work with a lot is adults with disabilities and how we have had them raised throughout the years. I'm an advocate that believes that I treat every single person the same. I talk to every single person exactly like I'm talking to. If I'm talking to a group of individuals who have intellectual disabilities, I do not treat them any differently or talk to them any differently or expect anything differently than I expect out of everybody else. When I had my office, they would come to the office all the time. I have lots of friends that have multiple disabilities that I go to lunch with, that I talk to on a daily basis. They're all, and I treat them all the same. And when I talk to parents that have children and youth with disabilities, I tell them right away, if you don't start making them accountable for their actions, you will have a problem as they start to get older. Because again, sometimes we forget and we let them get away with things that they shouldn't really get away with. Is that not true? Sometimes that happens. Sometimes we like to blame other people for things of their actions. I don't do that. I make everybody be accountable for what they are. I've worked with parents and gone and attended IEPs and 504s and student support training for about the last 30 years. So I know what the laws say, I know what the legislation says, I know how everything should work and go together. Well, when I attend meetings with parents, I let them know when I'm attending that I have never used a disability as an excuse. You can't use it as an excuse. Well, their behavior is because of this? No, that's an excuse. Their behavior is a choice. It could still be a consequence because of a disability or a mental health issue. But we have to still understand how to make that come into effect. And if they're breaking the law, they're breaking the law. But I also have a lot of my friends. In fact, I have one that I've advocated since she was in the second grade, who is this year graduating from college. Who, if you looked at her IQ of 52, would say she never would have been a person to go to college, and she graduates this year from college with her associate's degree. It took her a lot longer than everybody else, but that doesn't really matter, right? Guess what? She is still graduating and will walk across the stage and give her diploma. But we can't use it as an excuse. We have to have them and have them become productive citizens like all of us, what we hope, or as much as we can. I go with local integrated health, and they have a lot of families that have individuals with disabilities to help them, their families also help them to live and figure out what the system is, because sometimes it is help maneuver and figure out the system, so that we can get the services they need put in place, because it is a stress on families. Now, how about all the people that we don't have a disability? Like, we say, talk about mental health, that's all including in disability. What about this? That's all included. Like I just told you a minute ago, I don't know in my 30 years if I ever met anyone that I haven't self-diagnosed after I've been talking to them for a while. And I'm sure if you've been any kind of field at all, y'all probably do the same things. But sometimes we have to remember that this, and my belief, is that this is an inclusive world. At the Nickel Center, in fact, we did a little, what is that called?
The black sheep values?
Yeah, what?
Black sheep values.
Yeah, that's it. So whatever that thing is called, we did. And there were two of the people that worked there that said, I know what your number one, I know your number one word. I know your number one word out of this whole list of words. And they were right. Because my number one word is inclusive. If we do not figure out how to be an inclusive, 100% inclusive, that doesn't mean I can exclude anybody from anything. Inclusive. That means whoever should walk through the door, we should be able to talk to, and we should be able to help. Whoever walks through the door, no matter how much they need something, we should be able to have the moment to be able to give them what they need. If it's you, I will take a moment to sit and talk. If it's a parent in crisis, because trust me, all of us that have children hope that our children will be born with every tool that they need. And it is a really hard struggle when a person with a disability or when a parent has a child with a disability. The divorce rate is higher for people that have disabilities, for parents that have children with disabilities, than almost any other population. Because it's hard. Because it's a struggle. Because not everybody understands it. Because things change. Right? How many of you guys in this room right now know somebody that has a disability? Right? And what if that person is the people that we have, not by choice maybe, but because we felt like it was needed, that they were on medicine, because sometimes somebody does need to be on medicine. But that's the person that has grown up, that has learned to self-medicate. And then had trauma. and then add child abuse, and then add all of that, and you've got a person that's going like this all the time. Sarah said a minute ago, when she talks about all these acronyms, I try not to do acronyms because I can mess them up. The next thing I'm really good at messing up is cliches. Cliches. You know, don't think the horse will water, water will drink, won't drink, will not drink. Whatever those cliches are, I know so something. My husband always says, please don't ever do that. I also am a absolute 100% worse speller than any of you have ever seen in your life. And that's my friend. And I spell words exactly how they sound. And when I write it on a whiteboard, and I tell everybody in the room, look, I have a severe learning disability. If you understand what it says, don't correct me. You know, there's always 10 people in the room that correct me. Did you know you spelled that wrong? Hey, you missed an H. Did you know I had an ER? Don't look at me, dog.
No, tell me what your minutes.
My minutes. Okay. I'm only going to tell you this because she wants me to, but her organization, Family Connection, decided to let me secretary of the board. Now that sounds like a smart thing to do, don't you think? So they did. So you guys know how do you go to board meetings or any kind of meeting? And if one person says one thing, does everybody in the room have to repeat the same thing? They just word it different. You know, someone says, "Oh, I think it'd be a good idea if we served water." And then someone will say, "You know what? We should serve water." And then the next person over here says, "We should serve water." So my board meeting minutes kind of go, person number one said, serve water. And everybody else said, blah, 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 blah. You know. I mean, is that not a board meeting? Now, why would they why would they ever let someone with learning disability to be the secretary? I have no clue. I didn't like it. I'm not going to repeat every word that all these people say in all these board meetings. So imagine how a kid feels when they're in a classroom and we're asking them to take notes from the board and then from what we say. Wow. Okay. Blah, blah, blah. Blah, blah, blah. And then after they get bored with that, they're just going to start talking to somebody else. Right? Is that not true?
Yes.
They didn't let me be secretary again. I noticed that. I noticed they didn't. They decided that would be good. But here's the next piece. How many times, not knowing, do we criticize someone or correct what they're doing? And we might not know that that might be a disability. Or somebody that has gone through trauma. Or somebody that, any of those circumstances, you could say the wrong thing and you could flash them back to when they were a little kid and they would be back under the table getting corrected. That happens a lot. And sometimes it's how careful we choose our words and what we say and how we approach it or how we don't approach it. And those are some of the important things I think MIH talks about. I think that's the important things that in the Nichols Center we talk about. And I think that's important that we remember that if we do not accept the people, whether it be a peer that's walking through the door, because none of us know the road that somebody else has traveled. Is that not true? I went to college to be a teacher because I wanted children to be able to go to school and not feel as bad about school as I felt when I was a kid. I went through tutoring for 12 years so that somebody could teach me how to spell, so that I could learn my multiplication tables, so you could figure out all that. And I could name 100 other kids that I know that are exactly like that. But then I couldn't do the elementary and secondary math class very well. So when I did that, I got evaluated and found out that's when I had a disability, and I was over in my I'm still young. I was in my 30s. and a single mom. But I look at kids now and I look at some adults now, and they come with multiple packages of somebody with a disability, someone that had a lot of trauma in their life, someone that has come over here, someone that now has maybe gone into addiction and is now trying to be clean and sober. And they're carrying all these different suitcases as they walk around, wondering who they are to set them down. And then they try to travel a path. And sometimes that path is not always straight. Sometimes it is the yellow brick road. Many times it's the yellow brick road. For a lot of us. Like, why do you become a police officer? To help people. Why do you become a social worker? To help people. Why do you work with the aging community?
To enhance their lives.
To enhance their lives. Why do you work and do what you do? And why do you do that?
To serve the community.
To serve the community. MIH, why do you do what you're doing? Why are you working for Cobb Public Health? Lori, why do you do what you do? Stephen,
I do it for a selfish reason. It makes me feel good to help people.
all of us have a little bit of that too, right? Eddie, why do you do this? Why are you guys doing?
To help people in the serve.
Adiola, why do you want to be a counselor? Why are you a therapist?
To strengthen each individual and to empower them.
Kate, why do you want to do this?
Because when my child had cancer, I couldn't find there.
Wow.
That's absolutely right. A lot of times we all come with a personal reason too, right? We all try to travel a road so that we can figure out what we can do. And sometimes it might be because our part of the yellow brick road has now left us and guided us here. I do what I do and have been doing this for 30 years because of my path as a little tiny kid. To figure out where I wanted to go. To figure out where we travel. To become a police officer. To become a therapist. Christian, why do you do it?
My calling.
It's your calling. Tara,
Great belonging.
create belonging.
Help people.
Help people. Why do you guys?
I'm in community just to find the resources to be able to help.
That's a good one.
I've been a recovering alcoholic for addict for 30 years. And I struggled for 25 years to stay in the room. And I do a big Zoom thing with the AA and NA community.
Right?
And I'm retired from this in the course.
There you go.
Very message.
Thank you.
It works.
Phyllis.
I do it for people to be know that they are valued and seen.
Why do you do it?
I'm in human resources and my population is our employees. So my purpose is to serve and to educate.
Tutor.
To welcome folks and support people.
Without wanting to do it for me. Yeah. What about back here? Why did you become social workers?
If we have my resources to advocate for people and make it a little bit easier.
Sierra, gee, a lot of advice. Every single person in this room, man.
Oh, it's obviously because I didn't want to be a millionaire.
We have not done freedom. There you go.
So many reasons, but the one that's standing out the most right now is to be a light in someone else's darkness.
So every single one of us in this room are in this room because of that same common cause. Imagine how much we all do together, especially if we're part of a bigger picture like C3R. Especially if we're going to travel to another community and help them figure out how to do this too. There's a family connection in every single county in Georgia. Every single county, there's a family connection. Every single one is targeted to the resources of what that community is needing. That is the reason all of us come. That's the reason we're all in the room. Because in our hearts, always, we carry the passion that carries us every day to be able to do what we do. Mine is disability. Mine is inclusiveness. Mine is that we can all do this and work together and figure out how to make this a better place for all of us. You guys, we're gonna have lunch. Are all of you hungry? We're gonna have lunch. I think it's at the back of the room.
Yeah.
And we'll have lunch and then we'll come back. So we have 1 hour lunch break, network. There's lunch boxes in the back. You can pick which one you want. Check out the resource tables outside. Visit with each other. If you don't want this food, you want to walk across to the water fountain. There's a lot of great businesses. Probably pizza's great. You know, get some lunch out. Do
They should see it. It's a little block out in the that's what see. Yeah. You're welcome.
Welcome back. Push. Nothing. Great. Great. Thank you. So grateful. I'm excited about the next series of sessions that we have because we're going to continue that conversation. I think Phillips. He is highly accomplished individual he has a very fellow active. He is an highly accomplished individual that they are getting law is very self active. And that's sufficient that they are getting law Christians here. Exactly. Actually, we're going to turn it over to Ms. Ebony Phillips. So if you could, please welcome our
I don't know. But that wasn't good. Yeah, that's why I couldn't make like a video.
Thank you very much, Tara. I am so grateful to be here. Thank you for
Ebony Phillips. So if you could, please
amazing,
welcome.
amazing event. Your words are very kind. I hope I can live up to each and every one of them. Just a little bit about me, because I think I want to just give you some perspective from which I approach this work. I am, as Tara said, an attorney by trade, and I am the Director of Programs, Accountability, and Community Engagement for the Douglas County District Attorney's Office. And in that role, I oversee all of the non-traditional prosecution. And we'll get into what I mean by non-traditional prosecution in just a minute. But if you could think like second chance programs, right? Things that are not going to take somebody directly down the litigation path. And so I want to make sure that you also understand that this is my heart. And I say that because that's not really what prosecutors are known for. We are trained to figure out what the law is, what infractions have taken place, and how to prove our case, and in often cases, what the sentencing recommendation should be. That's kind of a simplified version of it, but that's really what it is. But in the social impact space, in the second chance space, it requires an entirely different approach. And I can tell you that I've been practicing a long time. I have done civil work. I've done all sorts of any number of kinds of law. And this is some of the most impactful work I've ever done. I tell my team on a regular basis, somebody's got to make the semiconductors. Somebody's got to make the French fries. But when we step foot in the courthouse, we change lives. And that's pretty amazing because not everybody that goes to work every day can say that. But what we also know is that there is a ripple effect. And if I can change one person's life, I can change generations of the family. And that's super, super impactful. And so that's the lens from which I approach this work. And I did see two of my team members come in. I have to acknowledge them. They're amazing. I can't do this work without them. Patrice is here. Wait, Patrice. Put her on the spot a little bit. Justin's here. Because it really does take a village for this lift. It's not a light lift. And this kind of lift is different from the traditional prosecution lift. And it's not that it's less work, it's just a different type of work. And it's all hard work, but I think we do the heart work, right? And the heart work pulls at you and gives you secondary trauma, sometimes vicarious trauma. And there's a toll that you have to pay for the work, but it's so rewarding that you just pause, take a breath, and get back in the ring and start back working. And so what I want to do before we start, I want to just give you an overview of kind of where I think the session will go, and it'll go wherever organically it grows just based on your participation as well. But I think just three main points that I thought that might be helpful for our conversation on helping our families, on building resilient communities in the mental health space. I do want to talk about just some statistical grounding because I think that's important, and then some legal theory, not very deeply, very surface level, but I think that's important because the way that we are approaching whole community wellness, whole person wellness is different from what historically has happened. And honestly, it's different from what the system was built to do, right? And so we need those kind of foundationals. And then I want to talk to you about what our office has done in terms of programming and collaborations. The Nichols Center is one of our great, great partners. We're so lucky to have Tara and her team. And then I want to talk to end on some high impact integrations across disciplines that anybody can take that don't require additional funding, don't require additional personnel. You could start it today if you wanted to, right? And so with that, I do want to say, for me, the why it matters, we're talking about numbers. 40% of inmates suffer from mental illness. So that's about 4 in 10. That's a huge number. Now that's an approximate number because, we have underreporting because people aren't connected to services. We have self-reporting, but usually any of the larger research studies that you pull from, they're going to put that number at approximately 40%. A staggering number though, a number that should make your heart skip a beat, is that 70% of individuals with diagnosed mental illness have experienced some form of trauma. It is the driving force behind the decisions they make, how they conduct themselves, and usually where they land, right? Where they land in life. And so there's going to be some overlap in those two populations, but that is the heart of this work that we do. And I think it's important for us to just punctuate that we look at the person first and then figure out a system that can assist versus the other way, which is the system is pre-existing and we try to force the person to fit in the system without addressing what their issues are. So level setting there, 40% of inmates have some form of mental illness. 70% of individuals with mental illness have some form of trauma that they're reporting. And so when you think about trauma, right? And you can shout it out. I'm wondering, just knee-jerk reaction, words that just come to mind. Somebody says trauma. So-and-so had trauma, or so-and-so experiencing trauma. Anybody? Abuse, that's the big one, yeah.
Childhood trauma.
Childhood trauma. Those ACEs, if you start, as a child with trauma, and it's unresolved and untreated, it shows up in the adult criminal justice system in ways that people don't often recognize. They just assume that the person is being difficult, non-compliant, and defiant, when really they have a lot of unresolved trauma. I pulled this because I know it can look different for everybody, but PTSD, some sort of terrifying event, that's the other thing that people don't often think about, is sometimes it is not like primary trauma, it is secondary trauma, particularly children witnessing events that are terrifying. And then they carry that through their lives. The hypervigilance is very disturbing to some people. Somebody gave a stat earlier about how people with disabilities have higher divorce rates. And the same thing happens with people with mental illness as well, I think. I don't have like the exact study for that, but just knowing that people that I know personally, there was a young man who was a very bright spirit, had experienced some childhood trauma, and he can't sit in a room for longer than 5 minutes without walking back and forth to the door or looking out the window or walking down the driveway. And it was just too unnerving for his partner. And they had a beautiful relationship, but for the fact that that trauma that he was exhibiting was triggering something in her too, right? And so the two of them couldn't coexist, and they both had unresolved trauma. So it's incredibly important that we look at it through those lenses. Has anybody in here been around somebody, either you're working at a nonprofit, you're in the court, you're in social work, whatever, and you see somebody exhibiting signs, certain behaviors that look kind of odd, but you're not quite sure what it is? Like, right? I feel like we probably all at some point in our lives been around that. I think most immediately about if you're in a public space and there's this unexplained outburst by somebody, right? And everybody's kind of looking, nobody really wants to look directly at the person, but they don't want to look away in case they need to find the exit. Um, and sometimes that's where law enforcement gets involved, right? Because it's a disruption and it's unnerving for people. And they might even say things like, I'll kill everybody in here, right? Well, that's a crime. And so when we think about those kinds of things, we have to figure out sort of as a court body and a prosecution arm, which is where we are in our work in our office. What do we do with, you know? And some things that kind of, come up is like, is it non-compliance or is it mental illness? They miss court, right? Were they being non-compliant? Most of the time you're gonna get a bench warrant. Just no questions asked. You miss court, you get a bench warrant. And then when you get a bench warrant, you're getting arrested. And the cycle continues. Or if you've been mandated to go to some kind of group session and you don't go, that's non-compliance. You're going to get sanctioned for that. But maybe you're not going because you're depressed and you are in one of your isolation phases. Illicit drug use. Well, illicit drug use is a crime. But we've been talking all morning about self-medicating to try to medicate through trauma. And so when we get cases in our office, and we're very fortunate that our district attorney, Dahlia Racine, has authorized us to take a non-traditional approach, right? To try to figure out what the root cause of the issue is. Not just looking at the case facts, right? Because that's sometimes surface level, but trying to figure out how they got here, why they got here. And the things that we see often, and I'm sorry this is so text heavy, I had technical difficulties, but aggression, right? Impulsivity, withdrawal, risk taking, non-compliance. Now, we're not clinicians in my office, but this is the stuff that lands on our desk though. So we have to deal with it. And I can tell you that a lot of behaviors that we see could be caused by mental health or by non-compliance. And somebody's got to try to sort that out, right? If we're trying to be about trying to do the right thing. And so it might look like aggressive behavior, and somebody might even put hands on somebody else. Or like I said, make those overt threats. I'll blow everybody up in here, those kinds of things. But it could also be that they are having an episode, right? Impulsivity, that's a big one with the people that we work with. And then the question that we always ask is, well, why did you do that? And they're like, I don't know. And they really don't, right? But the impulsivity leads them down a road that could be result in breaking the law. Withdrawing, they're on probation and they're not showing up for a single thing that the judge mandated them to show up for. So now they're about to be revoked and have a prison sentence attached. Risk taking, looking for that thrill, which sometimes means that they are breaking the law, and then also non-compliance. And I wanted to level set that for us because those aren't just charges and cases, those are people. That's somebody's mother, father, son, daughter, and they need our help. They need us to intervene in a meaningful way. And I know there's a tendency to treat symptoms, I'll say, right? But when you treat symptoms, you never get to the root of the problem. It just reoccurs. And in our line of work, what that means is they keep getting rearrested. They keep coming back to court. They keep coming through the criminal justice system. And so, anybody heard of jurisprudence before? Like I transparently, I hadn't heard of it before I went to law school. But simply put, right? Because now we're at the intersection of mental illness and the court system. Okay. And jurisprudence is sort of how do we as a society want our court system to function? What should the court system be doing? Who the players are, and what should they be doing in them? And it's supposed to kind of explain why we have laws and what we want the laws to achieve. Now, there was a point in time where I'm sure this level of jurisprudence was the latest and the greatest and the newest shiny thing, right? But now we have years and years and years of history behind us. And what history has shown us is that the traditional jurisprudence doesn't work for everybody, right? It just doesn't. Because traditionally, like I said, you're looking at who committed a crime. Can I prove the elements of the crime? What should the sentence be? Period. It is more of a societal tool than a tool for community. And the difference is society looks at how can we keep our system going? How can we keep peace and order? All the things. Community is looking at who has been harmed and how do we heal the harm, right? And so there was a social scientist who said, you know what? Let's look at this jurisprudence and how we're doing this. Because you keep talking about all these people that are repeat offenders, the revolving door, all the things. Is there a way to intercept that? Can we change that? Can we move away from the definition of insanity, right? Doing the same thing and expecting a different result. And so this notion of therapeutic jurisprudence was born, right? It was introduced in the late 80s. And it basically says lawyers and judges and people who work in criminal justice should act as healers. They should act as healers. They should exercise care and then to try to improve the outcomes of all involved, right? Traditional jurisprudence is looking at how do we restore the victim? How do we make the community a better place? All the things. But in therapeutic jurisprudence, the theory really is the system should be an apparatus for solving social problems. That's why the system should exist. That's the direction that it should be going in. Now, I got to tell you, because I'm a very empathetic person, because I was raised in a household of people who just serve, it made sense to me. But I didn't start there, right? There is nothing I learned in law school about therapeutic jurisprudence. And I graduated law school after this theory came about. And so I say that because sometimes we are going to be the lone voice in the room, advocating for whole person wellness, for therapeutic jurisprudence, for all the things that are not being taught in a traditional setting. And that's okay. That's okay. But we just need to realize that sometimes if someone is pushing back, it's not because they're trying to be difficult. It's not because they don't want to help the person. It's because their training leads them into a totally different direction, right? And so we want to be clear on that. And if you look at the two of them side by side, just some fundamental differences. In the traditional viewpoint, we're law enforcers. That's what the court system is. We're law enforcers. Therapeutic says, no. The law exists so that we can act as healers, right? In the traditional jurisprudence, we utilize skill and professionalism and knowledge, all the things. And then in therapeutic jurisprudence, we're exercising care. Can you imagine that? The court system functioning as treatment. It was not created to be that. But as a society, I think we get to evolve and shape what we need. And there came a time when we needed it to be that. And so in traditional jurisprudence, the thinking is that we're going to restore victims and we're going to restore the society. And then in therapeutic, you're saying, no, what's the best outcome for everybody? And that includes the defendant. And so that's going to include our individuals who are charged in our courts who may have a mental illness, a substance use disorder, all the things, right? So approaching it from that lens, it just makes sense as an extension of that to say, okay, this is the picture of the defendant. How do we address the problem? How do we make sure that they're supported? How do we make sure our victims are restored? How do we make sure that we center safety for our community, right? That is a lot to try to balance and counterbalance, but it seems to work better under the therapeutic model because we've shown that recidivism is greatly reduced when we take that approach. When we just keep throwing people in jail, they serve a sentence, they don't get any kind of support, any kind of mental health treatment, they get out, guess what they do? And it just rolls right. And so you see people who've got pages and pages and pages of arrest cycles on their records because they never had the proper interventions. And we don't want to be that. That said, our office takes a very non-traditional approach to jurisprudence, to case evaluation, to case preparation, to case disposition. As I mentioned, I supervise the unit that does the programs, accountability, and community engagement. And so if you think about therapeutic jurisprudence, you're thinking about anything that doesn't just automatically shuffle somebody directly to the trial line as a prosecution. Now, I do need to put a caveat on that because, of course, we're talking about nonviolent offenders. There are people who need to be shuttled directly to the trial line, and they go there immediately. But for others who are just dealing with trauma and life's ills, then we want to make sure that they get the support that they need and that our victims get restored. And so we have three main approaches that we use for that I'm going to talk about today. We have a number of pretrial diversion programs. We are also the office's representative, on the multidisciplinary team for Cohort. That's what we call our mental health court because we're very aware of stigma. So if you hear anybody in our courthouse talking about Cohort, they're actually talking about our mental health court. And then we also have therapeutic and what we call ACE bonds, and I'll go through that really quickly as well. Pretrial diversion is a way to divert cases away from traditional prosecution. And we're looking at low to moderate risk individuals, right? Low risk, low needs. So that is a lower risk of reoffending and a lower level of support that's needed. And there are commonalities to our program, like other programs that may be around, in the sense that they're going to have to do community service. Those individuals have to do restitution. We make sure that we support our victims. We accept their input in terms of how the case should be disposed of. And our offenders have to pay restitution at 100% in order to complete the program. Because, of course, this therapeutic model is looking at what's good for everybody. And everybody means the victim, the defendant, and all parties involved. And then we offer mental health and other interventions. And this population may or may not have a diagnosed mental illness. One of the things that we try to do is, and I heard somebody talking about it earlier, whole person wellness. And while we have them as a captive audience, we want to make sure that we pour into them relentlessly. And one of the things that we do is we have life skills modules that they have to attend to. And I won't go into the details of each one, but just know that, for instance, for our young people in particular, they're told a lot of times, you need to just get a job. Well, that presumes they know how to do an application and a resume and all the things. So the first module is career readiness and employability, walks them through the interview, all the soft skills that they probably have never learned from anywhere else. But then also the follow-up to the interview. And once they get the job, the second module is professionalism and workplace etiquette. What we were seeing a lot in our cases is that people were just doing what they had exposure to. So like they'd be on a job and the boss might say, well, you can't have Friday off, and they snatch the time clock off the wall and throw it out the window. Well, that's a felony. That's a felony. And in that moment, they weren't intending necessarily to commit a felony, but you know, what their exposure is if someone upsets you or says something you don't like, you act out to try to get their attention and make your point. And so that piece is very important. And then we have financial literacy, because after you get this great job, we show you how to keep it. Then, of course, you need to know what to do with your money. And we walk them through the art of saving, budgeting, and investing, which they really, really appreciate. And then we have um, values clarification and decision making, because again, with our young people in particular, some of them are young enough that their frontal lobes are not fully developed, and it's showing in the decisions that they're making. But we also are trying to be proactive. So our last module is social, emotional, and mental well-being. And these individuals probably don't have a diagnosed mental illness necessarily, but wouldn't it be great if we could raise up a generation of people proactively that understand when they might be teetering on the edge, understand who to call for help, when they need to call for help, um, but also having a safe space with their peers to talk about life stressors. I can tell you that I don't have a diagnosed mental illness, but life is lifing, right? And I have way more life experience than they have to draw from to try to get me through it. And so very proactively, we offer that. And then the licensed professional counselor who teaches that session, she's wonderful. Shavandra Dykes with Surviving Transition. Some of you may know her. She's been a great partner to our program, makes herself available outside of session if they have things that they need to talk through. And then we have an amazing collaboration with Nichols Center. We are part of a Motion for Justice grant that allows us to refer out to the Nichols Center for mental health, for parenting classes, for anger management, all the things that people don't necessarily have available, um, or if they have it available, they can't afford it. Just transparently speaking. But Tara and her team can do an evaluation, figure out what the exact needs are, and they tailor the programs around what the participants' needs are. And we're talking about trauma-informed care. One of the things that we do is what we call a warm handoff. Some of y'all probably know about that. So instead of just telling the folks, hey, you go to Nichols Center, we complete a very thorough referral. And then we make sure that Linda and those know that the person is now referred so that they can reach out to them, right? Because if they're in crisis, sometimes they're not thinking about calling Nichols Center. They're just trying to make it through the night. And so that's where these interventions come in and are very important. And we do all of this so that we can try to interrupt the cycle that would have them coming back through. The reality is that you know, there is reason for anybody to support these programs. For me, like I said, I'm an incredibly empathetic person. I have a heart for service. And so I get the warm and fuzzies when I can help somebody and change their life. But for people that's not their thing, I get that. But it is very taxing on the system to have the same people recycling in and out. It costs almost $8,000 a year just to house somebody in our jail, right? So we can avoid that. Those are other resources that we could be using elsewhere in our communities. But it also takes a case off the docket. So that case or 5 cases coming off the docket that we can move means that they can put 5 other cases in that place. So it really is a win-win for everybody. We also have Hope Court, as I mentioned, and Hope Court is one of the accountability courts, and that is not a district attorney's office program. That is a superior court program that's multidisciplinary. Um, and my team represents the office as part of that team. It's evidence-based, right? It is evidence-based. There's science behind it. Accountability courts exist all over the nation. All Rise is the national body that certifies all accountability courts. And then we have the Council of Accountability Court Judges here in Georgia that has peer reviews and all the things to make sure that we're following the standards. But it is an approach for high risk, high needs individuals, right? So if you think about somebody that might have, I don't know, 30, 40, 50 arrests on their history, that's the person we're targeting for this, right? Because we know that that 30, 40, 50 could be 100 by the time somebody intervenes, right? And they've cycled in and out, and they haven't had the proper intervention. Now, they do have to have a diagnosed mental illness. There are surveillance officers that are a part of it. And on the next slide, I'll talk to you about sort of who all's in it. But what you need to know is that this is a very successful approach, because it doesn't just say, hey, you committed this crime. Your court date is January 5th. You show up for court, you get reset, then you get reset again, then you get reset again. And by the time your next court date comes around, you're in crisis and you've reoffended. So now you got another case, but you didn't get an intervention from the first case. It's incredibly successful. But I will say that this is the multidisciplinary team, right? You've got the judge. The judge who presides over whole court is Judge Cynthia Adams. She happens to currently be the chief judge of the Superior Court of Douglas County. Does an amazing job. Imagine that judges wanting to do something other than put people in prison, right? I'm the felony prosecutor on the team, and then I have the assistants of my team that I introduced to you earlier. Public defender, the sheriff's office, the Department of Community Supervision. They were previously known as probation. We have a program administrator, there are clinicians, therapists, case managers. But if you notice on this slide, all of those people would traditionally be in some way or fashion trying to figure out how to prosecute the defendant, right? But we flip that model to say, with all of our collective knowledge, with all of our experience, with all of our different perspectives, how do we support this person to recovery and stabilization? Now, this is a court system doing that, and the prosecutor's office is part of it. That's pretty innovative, right? I mean, I'm not trying to pop my collar, but and that's why the arrows are pointing in towards the defendant. Excuse me, we call them participants once they're in, because we're bringing every single thing we have, every single resource at our disposal to participant A, to stabilize them, to support them to recovery, and then to support them post recovery. Because what we know is that participant, if they're stabilized, there's an amazingly high chance that we'll never see them in court again. So we could either do the supportive piece, or we can house them for another year or two, pay $20,000, $30,000, $40,000, let them out again, rearrest them, and start the cycle all over again. And some people would call that the definition of insanity, right? But this is another tool that we have in our office at our disposal for safe communities and for restoration and stabilization. The final tool that we have is what we call therapeutic and ACE reentry bonds. And ACE stands for accelerated court entry. Years ago, if you had a case or whatever, and you had a probation violation with it or some other things, you'd have to sit until your case came up for trial if you couldn't make your bond and all of that, right? That's traditional jurisprudence. That's how it happens. And so we started to notice that even though people were being referred to our accountability court programs, somebody said it earlier about how slow the system moves. The wheels of justice turn slow. Y'all ever heard that? Well, it was barely moving on some of these cases, and not for lack of effort, but just for sheer volume, right? And so we decided that we needed to figure out, how do we speed up this process? How do we get these people out of custody sooner? And not just out of custody though, because then if you just let them out, you're repeating the cycle again. They're going to get rearrested and come back, but out of custody and connected to services. That was really like the key piece to it. And so we came up with this. Well, first we had to get system partner buy-in to say, even though these people haven't come up fully on their trial calendars, we would like them to be bonded out, please. And I can tell you that, and and understandably so. That took a little work and a little time and a lot of meetings, but we got it there. We got it there. And so what used to be 6, 8, 9 months to get somebody connected to service, we've got it down to about three months now. And in some cases, 50 days, because best practices say 50 days is the sweet spot. Because what we also realized was, and I think this is the part that traditional jurisprudence doesn't always consider, because we're looking at, traditionally they're looking at, this is the case file, let's see what's happening, let me type some things in. But therapeutic jurisprudence is looking at, how can I help this person? And when you look at it through that lens, sort of what you're able to envision changes, right? So what we started to say was, you know what? If they're waiting 6, 8, 9 months, that means they've lost their job if they have one. That means they've lost their housing if they have one, if they have somewhere to live. And that also means that they've lost whatever support they may have, whether that's a brother, sister, mother, significant other. They usually are not, unless your mother, maybe, but other people are not usually going to hang around for the better part of the year while you're sitting in jail. People move on, right? And so it was important for us to figure out a way to connect them to services quicker, not just to make it go faster, although the evidence says that the quicker they're connected to services, the better the outcomes, but also so that they have some form of stability to try to come back to once we release them. And so we got the number down significantly in doing that. And so when they bond out, it's not just a regular bond. They have to connect immediately to the services offered by the mental health court, right? That's not optional. That is not like, hey, when you bond out, if you feel stressed or depressed, come on by the office. No. As a condition of release, you will come by. Now, our programs are voluntary. We don't hold anybody hostage. So if you're not in a place where you really want to kind of have a curfew and you're not ready to have a surveillance officer, you're not ready to have somebody asking you about your medication all the time, probably not the program for you. But for those who are ready and willing, it's available, and it's been an absolute game changer. It's been an absolute game changer. So we're very, very excited about what that's meant for our community, what it's meant for families of our participants. Because usually there's some family member on the other side who has been running themselves ragged for years trying to support this person, right? That's the nature of mental illness. And so we're very, very grateful for all of our community partners who came to the table with us on this and who said, okay, you guys want to try this? We're in. And it's working beautifully. I want to move to my last big segment, and let me level set that, lower your expectations. I don't mean big like grand, I mean big like big. One of the things that my team and I do is try to figure out how to get the best in our interactions with our participants, because what we know is, depending on what their trauma history is, what their history of mental illness is, or even substance use disorder, even though I'm a prosecutor, people still look at me and see the police, right? They see the system as one thing, right? And so they're not really trying to talk to the police. And because they're not trying to talk to the police, sometimes they're not even trying to receive support from us or services or any of the things. And there are things that we are able to refer out to our community partners, but sometimes it's us that they have to talk to. And we approach it from the perspective of not like, well, I'm trying to help you, right? No, that's not helpful. But it's more of figuring out how to gain that trust and that confidence in us so that they will open up. And so these are 3 things that have worked for us that I just want to share because I know one of the things that we have issues with, and I'm sure I'm speaking for everybody in this room. I haven't interviewed you all individually, but we're usually short on funding, and it happens kind of regularly. But there are things that you can do in your interactions with the participants that'll go a long way and that don't cost you anything. And that's what I just kind of wanted to end with. Um, Words have power, right? Words have power. And so our first approach is just to shift everyday language. Just shift and because the thing about it is that if we're not used to operating from a trauma informed lens, um, and let me say this too. So I have challenged my team to move from trauma informed to trauma responsive, right? And they're always like, well, now you came up with something else for us to do. But they always stand shoulder to shoulder with me and help me push the boulder up the hill, and I appreciate it. But when we're talking about trauma informed, the best way I can describe it is like, if I walk by Linda in the back and Linda has a broken leg, and so she has her leg hanging out, right? So trauma informed is, okay, I've paid attention. I see Linda has a broken leg, so I'm going to avoid it. I'm not going to kick Linda's leg. Linda's leg is broken, right? But trauma responsive is where you go that extra step, right? Where not only did I notice that Linda's leg was broken, I'm going to avoid it, I'm not going to kick it. I'm going to see if Linda needs some crutches, right? I'm going to offer that supportive piece. And so I've challenged them to, and so I feel like most days we vacillate, my team and I, somewhere between, I think we generally 9 out of 10 work in a trauma informed approach. And I think we're getting and leveling up to most days we're somewhere between trauma informed and trauma responsive. And so I'm very excited about that. But one of the things that we noticed early on, and then I started doing a little research about it, is that whether we're doing this work or not, words matter. Words matter, you know? And so just the little language shifts that you can make that kind of help people relax and not focus on the stigma that they may already be feeling around, whatever their challenges are. And something that I had said, and I had to kind of catch myself was, and I meant it in the most sincere, compassionate way, was like, well, what's wrong with you? But that's so judgmental and stigmatizing when you think about it. Because why does something have to be wrong with the person because they're experiencing something, right? And telling somebody to calm down, that's triggering. And in my mind, I might be saying, okay, calm down, right? So we can fix it. But they're already used to everybody judging them and trying to tell them what to do. And so instead of using commands, I try to put let's, right? So they know we're together and I'm not judging or making commands because I wouldn't be commanding myself. Let's do this. Let's do that. Let's take a break. Let's whatever. And a big one is labeling people. You're crazy. She's an addict. They're this, they're that. And I don't think it comes from a bad place. I just think it's like common nomenclature. But we have to be careful because whenever you do that, you're piling on to all the other times in their life they heard that and felt judged and demeaned and less than, right? And so what I train my team to do is to just describe the behavior. And it seems like it takes longer, but it's going to take much longer if you do it the other way, and then you have to spend so much time trying to calm the person back down. So you may as well do it that way to begin with. And so the impact that we get from that is that they feel respected. People who feel respected interact with you in a totally different way, right? And you can keep situations from escalating just by word choice. These are a couple phrases that we tend to use in criminal justice, and I've just offered some alternatives that have been helpful for me and my team. What about if somebody tells you to stop overreacting? Does that make you feel warm and fuzzy? Right? But that's a word that's used in criminal justice a lot. That phrase. And so you just kind of have to take a breath and say, I see this is overwhelming. It's moving fast, right? Let's slow it down. And that'll usually and sometimes you got to use more than one of these to be clear. But you can start on the road of de-escalation. Because if the situation escalates, I can promise you, and the parents in the room know what I'm talking about, they're not going to hear anything else you say. Nothing. And I think I mentioned this a minute ago. You're non-compliant. That's a label. Non-compliant is a label, and it doesn't have a positive connotation to it. But if you say, hey, I noticed you missed group. You want to share what made it hard for you to get there? Now, this doesn't sound like prosecutor's report at all, right? But it works. It works. We talked about calm down, failing to appear, and telling somebody to stop being difficult. Ooh, I'm trying to remember the last time somebody told me that. It didn't go well. But you get the idea, right? And these are things that you can do because the work that we do requires the participants to trust us, to open up fully and trust the process. And we have to remember that if they have trauma, and even when they don't, every other interaction they've had with the system has not been good. And in most cases, when we're talking about accountability court, we're talking about people with lengthy criminal history. So they've been to prison and back. So they don't expect anything good to happen at the courthouse. Nothing. Right? And so we really do have to break those barriers down. The second approach, and I like this one, is to offer choices, right? People like choices. Mentally ill or not, people like choices. Think about that. When you signed up for something and they say, would you like the t-shirt or the tote bag? It just feels special. These individuals, because they act out so much, because they have trauma, because they have all these external symptoms, are used to people trying to control them and control their behavior. Not necessarily from a bad place, but just to maintain order, right? So when you say to them, and I try to do that like early, right? Would you prefer to sit over here or over there? Now that's so small. That costs us not a thing, but that opens them up, right? You want to talk now or you want to wait a few minutes? Would you like the door open or closed? When I see that the situation might be about to go left, I'm looking for like anything in the room to offer choice. Would you like a red pen or a blue pen? Just something. I've got to get them to a frame of mind where, okay, she doesn't think she's controlling the situation, right? She's actually here to help. Because when you dictate terms, they're not going to open up. And so even as the prosecutor's office, the people that are charged with prosecuting crimes and sending certain individuals to prison, we get a great outcome just in offering choices. We call to onboard somebody. They're having a horrible day, right? We call them on board in the program. Baby's crying in the background. Sounds like somebody just dropped a whole dozen glasses. And instead of saying, well, you need to get that situated because I need to onboard you. Just a simple, would it be better for you if we called you back later? Oh my God, thank you so much. Absolutely. Right? Those are the kinds of things that you can do immediately that have huge impact and don't have a dollar value. And it can help reduce resistance because what you also want to do is store up like great deposits because there's going to come a time when you're going to have an accountability factor you're going to have to put in there. but you will have already had so many of these high impact interactions with them that they're going to be more receptive, because Ebony did come in the door trying to control me. She didn't call me non-compliant. She didn't tell me to calm down. We've been walking through this process together. And then you want to, and this is the last approach, you want to normalize and respond to stress reactions in the moment. And when we normalize stress for people, they feel like they're in a safe space. Because think about all the interactions they probably had where they couldn't say, I'm stressed out. I don't think I can make it. This is so overwhelming. And one of the things that I say to people, particularly our participants, they'll call and just unload their whole life, right? And I listen. That's also a big part of it, just listening without interrupting. But then when they take that pause, and I feel confident that it's my turn, one of the first things I'm prone to say is, "Oh my goodness, that's a lot," or "That sounds like a lot." Just acknowledging and normalizing that they're having a hard time, right? And that requires me and my team, because we're busy people and we're trying to get through our caseload and all the things, but that requires us to take the focus off of our to-do list and put the focus on the participant and what the participant needs. And so you want to recognize that this is probably a stress response and not just quote unquote bad behavior. You want to ask them if they need a moment. That opens people up, right? That acknowledgement, and then they'll take a break. And tone is important too. And at my grandmother's house, she would match it tone for tone, right? Because you're not going to talk louder than her ever in her house. It's not ever going to happen. And then it just keeps going up. And so, because I had that experience, I had to really be intentional about when somebody was ratcheting up for me to stay here. And that's way more effective than every time they go up, I go up, right? It is these kinds of things that are going to build the trust that you need to be able to support the person fully. Trauma responses of fight, flight, and freeze are often misinterpreted. Sometimes people are just triggered. They're not trying to defy you or challenge your authority. They're truly, genuinely triggered in that moment. And they don't have either the coping mechanism or maybe just not the capacity in that moment to handle it in a different way. And so we want to be very careful about that. My team knows I love quotes, so here's the one that I'll end on. The past is never dead. It's not even past. And I don't know that that great American author, William Faulkner, was even talking about trauma when he wrote that. But when I read it, that's what I heard in my head. I am very, very thankful for this collaboration, for everybody in this room who's doing the heavy lift day in and day out, often at great personal sacrifice. I love Douglas County. I love being able to say that when I go to work every day, I change lives. I'll continue to do that. And with that, I'll take your questions. Any questions?
Hey, I have a question regarding the Cohort program, the Cohort. Is there an age criteria? Do you take juveniles and adults?
So the Cohort program is for adults, and in the criminal justice system, adult can be as young as 17, depending on what the charge is. But our Douglas County Juvenile Court does have some similar programs for juveniles. Christy Wilson is our deputy chief over juvenile court, and she'd be able to tell you more specifically about those.
And last question is, since this supporting piece has been put in place, have you seen a decrease in recidivism with repeat offenders?
For sure. So with respect to pretrial diversion, our in-house district attorney's office program, our recidivism number is less than 10%. Less than so, another way to think of that is When people leave our program, probably only about 1 out of 10 of them is rearrested. Thank you. Anybody else? All right. Oh, I'm sorry. Go ahead.
Have some, Resilient Georgia Trauma Informed First Responder Organization, information for them that they can take. And I won't go over not many, but you can take these and they just have some more resources
Thank
available.
you. I would love that. Thank you so much. Absolutely. The more the better. Yes, sir.
I have a question. Does the does the Douglas County Jail have a mental health clinic? And in that mental health clinic, do you have a clinician as well as a discharge coordinator and a transition coordinator?
So, as I understand it, and it's the first question is yes, they do have kind of a what I'm going to call the mental health board. They have a psychiatrist, but it's not a 24/7 situation. I think he might come out once a week or once every couple of weeks or something like that. And then the discharge coordinator, if I'm understanding the way you mean it, I don't think it's titled that, but they have a gentleman that works in that arena. And then we actually work directly with the mental health board at the jail as well, because they are often identifying people that they've noticed that may be symptomatic, that probably could benefit from being in our program. And so there's that collaboration there.
Thank you.
Mm-hmm. Yes, that's it. Okay. Thank you all very much. I'm at the district attorney's office if you need me later.
I think that's between Brandon.
We're gonna take a 5-minute break and then we'll come back. Oh, this one right here. And it's real simple. You just use this button right here and it'll, when that green is on there, that's like that. I know. I was telling her about our life. She said she's interested. I'm interested. I want to know. It's not worse now. I am very interested. Love to add to that. Then I will actually. She knows the toys. I would so much fun. You could be the signature. Oh,
I have my own bag that you bring.
Of course, thank you. Have a good day. All right, you too.
Yeah, I've seen her. I thought it was just crap. All right, everybody, how are we doing? How we talking about the family deal? Everybody good? Still with us?
Awesome. My name is Christian and this is Adiola. We have the honor of being pre-licensed therapists at the Medical Center. So we both graduated last year, 2025. And so we were able to do our internship there as clinical interns, and now we're in the process now like that whole licensure process, which is a long process if you know anything about mental health and being an LPC. So we just wanted to talk, we're just gonna talk for a couple of minutes about some of the stuff that we've done actually in partnership with what Attorney Phillips was talking about some of the program promotion justice and what that looks like and some of the clients we've had the opportunity to work with. Adil and I have been able to lead a lot of the groups. So have a parenting group that we offer. We have an anger management group, and then we also work with individual clients. We have clients, but I have a client that's like 4 years old. So yeah, they're pretty young. So we have clients who are really young, and then we go all the way up. As far as that goes. And so one of the cool things that we do through the Medical Center is we have a partnership with the Trinity Center. So we have the opportunity to work with clients that are being referred to us for clients who have experienced different various types of abuse. And so we not only get to work with that client, but also work with their families as well in that healing journey, that healing process of what that looks like for them individually. So yeah, that's some of the stuff we get to do. Adiola, you want to kind of talk a little bit about the groups and
Sure. I mean, one of the things that we've come to understand with, especially the nurture and parenting class, is that a lot of the individuals that are coming into the class, they really just need the right place to be nurtured and grow and understand that, like, I'm not, my path. And so the beauty of our group is that we're unlearning to relearn a lot of times. And what do I mean by that? A lot of the parents, sometimes they have never been taught how to, actually love on their children, and they're carrying past trauma and bringing it into parenthood. And they're just passing it on to their children. And oftentimes they wonder, well, why is my child like this? Why is my child like this? And not really having the clear understanding of the root cause. And so in the parenting class, we have the opportunity to really dive deeper, teach them some of the terminologies that maybe they've kind of heard, but they didn't quite really understand. And then also, how do we start reframing some of our thought processes, as well as how do we stop, similar to what was presented to us earlier, stop labeling our children? So rather than saying that, my child is stubborn, for instance, right? Perhaps this child is just really strong-willed, and then perhaps that child is just really determined. So really teaching the parents, like, how do you properly, work within the home so that when your child goes out, they are still confident. Oftentimes, we also notice that, a lot of the parents, when a child has low self-esteem, if you look deeper, it starts from the home because a mother that they trusted, a father they trusted, a grandparent that they trusted, or somebody within the family has talked down on them, such as something as simple as you smile too much, you talk too much. And so guess what? A child goes out and they don't want to talk, they don't want to say nothing. And you wonder, well, they're greeting you. Why are you not saying anything? Oh, your teacher is talking to you. Why are you not doing anything? So when we work with the parents and teach them that there are other ways, I know that you have the best intention, but there are other languages to use, to still get your point across. They're at that point in time a little bit more, calmer, they're reserved and they're able to learn. And then they are also unlearning to relearn and to help their children as well. So we enjoy it. And I mean, if we're talking about race to resilience, one thing that we've also come to understand is with every client that we've had, the resilience is already inside of them.
and they really just need people who can help them articulate their feelings and help them understand that it's okay to ask for help. It doesn't mean that, you're incapable, right? It's okay to cry out, when you are in, emotional distress, right? It's okay to, take your time to review. And so those are some of the things that we get the opportunity to do with our clients. Yeah, it's an awesome opportunity. One of the things that I've loved doing before I came into therapy, I worked a lot with children and youth. And so when I came to the Naval Center, I was like, oh, that's my client base right there. That's what I want to focus on. But through that, I've also got an opportunity to work with the family. So like Adiola mentioned with our parenting classes, but also doing family therapy, which is something that's been so beautiful to be a part of really rebuilding relationships, like children rebuilding relationships with their parents rebuilding their relationships with their children, things that they found out, even like hearing parents share their stories, and their child never knew their story. It's just like, I just thought you were mean because you're mean. Like, I didn't realize that you went through trauma. I didn't realize that you've gone through things and that you have different disabilities or disorders that you are challenge that is a challenge for you, and then you're also trying to help me with mine. And so being able to be a part of that piece, Adiola works a lot with couples as well too. So we also offer couples therapy and just really rebuilding that unit as well. So it's been an awesome opportunity just to continue to do the work and continue to help families heal and love what we do. Any questions before I pass it over to Officer Tibbetts? Yes, Miss Shepherd.
What did you guys say would be a couple of things you've learned since you started doing this kind of work and working at the Mental Center?
You go first.
I want to ask me questions.
Man, there's this saying that, and truly, we talk about, cognitive behavioral therapy, CBT, right? That as a man thinketh, so is he. And so, oftentimes, before you do something, you already processing about it, right? And then not recognizing that because you thought about it, guess what? It starts affecting how you feel and your behavior. And that's something that we have learned, even being at the Nick Center, is that you have to be able to help this individual, whether it is mom coming in, dad coming in, or even just a child coming in, or an elderly person coming in because they have, retired and they feel like they don't have any sense of purpose anymore. And so helping them to rethink, and also understanding that you still have a purpose. So those are some of the things that we learned. Also, I have learned that you have to be able to, like, literally stretch yourself as, a therapist. And earlier I was joking with our MIH team back there because during internship I had an opportunity to go in the field with them, and that's something that I had never done before. And so it was very eye opening. Oftentimes, when we are so like when we are boxed into our safe zone, it's hard for us to think outside of the box. And in order to really help a diverse group of people, you have to be able to think outside of the box. And even perhaps maybe you never, like she said, maybe you were so sure that, children are those are my demographic and that's all I'm gonna work with. But by the time you stretch yourself and you come with an open mind and you're willing to work with other demographics, guess what? Even if you still end up not choosing to work with that demographic, you have a greater understanding because when you still work with, children, you can think from an adult perspective, what have they gone through and how can I begin to help this child based on what they are sharing? So, yeah. I would also add to that something that I talk about a lot because it was a conversation that changed my life. What is this mindset of creating space? And so, like I said, when I first started at the Nichols Center, I had a specific demographic that I wanted to go for. Like I really wasn't open to anything else. And but quickly I learned being at the medical center is that there was a lots of opportunity for many different groups of people. So one of the first things I did was I had the opportunity also with Miss Linda to be thrown into a men's group, and we led a men's group, and that was very different for me because I was like, what do I have to say to this group, you know? But I realized from that moment, and we did some women's trauma groups and family things of nature, I realized in that moment that everybody just wants space. They're looking for a space. They're looking for a safe space. That's one of the early conversations that I actually had with Tara was that your job is to create space and create a space for people to heal, create a space for people to discover who they are. That there's more layers than maybe the way that they've always been told or that they feel like they present as, but like what is the underneath behind all that? So that's something that I feel like I have learned a lot being at the medical center is that everybody's just looking for that space, whether it's something they just want to share something, they have a thought they want to share, they want to work through some trauma that they've been through, or maybe that they have struggled with addiction in the past and they're trying to really, I just need you to hold space for my recovery, like whatever that may look like, they're looking for a space and they're looking for it to feel safe. And that's one of the things I love about what we have. If you've never been to the center, please come by because it is such a beautiful place. It's such a beautiful space for people to begin to start that journey of wholeness for what that looks like for them. And so just being able to be a part of that has been one of my greatest joys. Any other questions before we pass it over?
Guys are Tara's intern.
We were interns. We're no longer interns anymore. But we are still at the center. We're still there. We're still at the center. We are so we have three
Big CCD on my desk. You expect me to sit in my
Yes, and also too, an additional thing that we do, like we talked about, is that we do have internships. So right now we currently have 3 interns that are with us as well. And so we offer internships for grad level students as well as bachelor's level there. And then we also have volunteer options for even high schoolers who are looking to kind of like discover mental health. Some of our high schoolers were like, I'm interested in psychology or I may study this in school. And so they'll come and they'll volunteer with us just to be able to be around that environment and be able to see what we do.
We have volunteer, how old is our oldest volunteer? Then Janet, oh, 92.
90, yeah, but that's in the 90s.
92.
Yeah, and she's still, she can do more than I. Yes. So yes. Well, I'm gonna go ahead and pass it over to Officer Tibbetts, and I'm gonna let her take control of the room.
Good afternoon, everyone. I'm Officer Tibbetts, Powder Springs Police Department. I'm here to represent the peer support team that's just recently been started back last October with the city of Powder Springs.
You should be.
So first of all, before we get started today, how many clinicians do we have in the room? You guys are the real unsung heroes behind the scenes. Thank you all for what you do. Let's give them a hand. There's some things I'd like to talk to you about today, and importance of officer mental health, peer support in policing, resources we have available in the state of Georgia for first responders, and building strong programs. This afternoon, I'm going to share with you not only my story, but how our peer support team got started and the stories of 2 other officers that I've found while putting all of this together. My personal story is I've got 6 years of law enforcement. I came out of the police academy, much like every police officer. I thought I was going to
take on the world and solve all the world's problems, become the next police chief, and be Superwoman. Little did I realize life happens and all of that. There's a lot of things that we deal with behind the scenes that folks are not aware of. Some of those being, in my case, organizational stress and professional challenges. I've faced quite a few of those in my time. Personal level, I lost my dad. Twice in my 6-year career, I've lost my home through circumstances beyond my control. And most recently, in the past year, I've been dealing with a very serious medical condition. These experiences have taught me that life is a gift and every day is a blessing. But what I realized, especially in the past year in dealing with this illness, there's going to be other officers out there who are facing challenges in their personal lives. I had a lot of time about a year ago to sit and think about my career and what was really important. When you're faced oftentimes with a medical condition, it puts a lot of things in your life into perspective. So why this matters, it inspired me to become an advocate for officer wellness, promote mental health awareness, and advocate for peer support for first responders. Behind every badge is a human being hearing things that most people never see. Oftentimes when we're out there on the streets, people see us as a uniform. They don't see that there's a human being underneath this uniform that has feelings and emotions just like everybody else. I'm going to share with you a story about a captain named Adam Myers from the Hartford Township Police Department in Wisconsin. I had the pleasure to speak with him this week. So if you'll bear with me, I'm going to read a personal story that he wrote about his experience in dealing with his own mental health after a critical incident. Across the United States, law enforcement agencies consistently say they want experienced officers, people with years of obtaining real-world decision-making experience and ability to handle the complexities of modern policing. Yet, paradoxically, some departments hesitate to hire highly qualified veteran officers. Their background includes documented mental health challenges stemming from a critical incident, even when that officer has fully recovered and now actively and publicly helps other officers with their mental health. This hesitation often has less to do with the officer's actual ability to perform the job and more to do with risk perception, liability concerns, and lingering cultural stigma surrounding mental health in policing. Police departments operate in an environment where every hiring decision carries potential legal and public consequences. Chiefs, sheriffs, and municipal leaders often consider the possibility that lawsuits or critical incidents when evaluating applicants. When an officer has documented mental health treatment following a traumatic on-duty incident, some departments worry, fairly or unfairly, that hiring that officer could create negative public perception of the municipality or legal exposure. If something goes wrong in the future, administrators may fear questions such as, did the department knowingly hire someone with a documented psychological history? Was this officer fit for duty when the department hired them? Even if the officer has been medically cleared and demonstrates resilience and stability, the perceived legal risk can influence hiring decisions. Most, not all, police agencies require psychological evaluations during the hiring process. These assessments are designed to identify traits that could affect judgment, stress tolerance, and decision-making under pressure. However, psychological evaluations are inherently cautious tools. Evaluators often make a conservative approach because their recommendations can affect public safety. If an applicant's history includes documented trauma responses, therapy, or stress-related diagnosis, even when resolved, some evaluators may classify the candidate as a potential risk. The result is that an officer who demonstrated the courage to seek help after a traumatic incident may face additional scrutiny compared to someone who never reported or addressed similar struggles. Despite growing awareness of officer wellness, policing still carries a long-standing culture that values toughness, emotional control, and resilience under extreme pressure. Historically, officers have been reluctant to discuss stress, trauma, or emotional difficulties out of concern that it might be seen as a weakness. Because of this culture, some hiring boards may quietly view documented mental health challenges as a red flag, even if the officer has successfully recovered and performed effectively afterward. Ironically, officers who acknowledge their struggles and seek treatment may face more professional consequences than those who silently endure them. Another factor is simple practicality. Hiring committees often review many candidates. If two applicants appear equally qualified on paper, but one has a documented mental health history tied to a critical incident, some departments may choose the candidate without that history simply because the decision feels administratively safer. This does not necessarily mean the department believes the officer is unfit. It simply reflects a desire to avoid uncertainty. Municipal insurance and risk management groups can also influence hiring practices. Departments operating under municipal liability coverage or self-insurance pools may be cautious about hires that could potentially increase perceived risk exposure. Even when there is no normal policy against hiring officers with past mental health treatment, administrators may interpret risk management guidance conservatively. Ironically, officers who have faced trauma, sought help, and recovered often possess qualities that can make them exceptional assets to a department, like a deep understanding of critical incident stress, strong empathy for fellow officers, credibility when discussing officer wellness, commitment to healthy coping strategies, and real-world experience in managing adversity. Many of these officers go on to mentor others, advocate for officer wellness, and help reduce the stigma surrounding mental health in policing. In many ways, they embody resilience rather than vulnerability. The law enforcement profession is gradually evolving. Increasing attention is being paid to officer wellness, peer support programs, and psychological resilience. Departments across the country are recognizing that trauma exposure is an unavoidable part of policing and that seeking help should be viewed as a sign of responsibility rather than weakness. As this shift continues, many agencies are beginning to understand that an officer who has confronted trauma, engaged in treatment, and emerged stronger may actually bring valuable perspective and leadership to the profession. The hesitation some police departments show toward hiring experienced officers with past documented mental health challenges is often rooted in risk management, liability concerns, and cultural stigma rather than the officer's actual capability. Yet, the profession is recognizing a critical truth. Resilience is not the absence of struggle. It's the ability to confront hardship, recover, and grow from it. Officers who have walked that path may ultimately be among the most valuable leaders in building a healthier and more sustainable future for law enforcement. When I read that story, I could wholeheartedly relate to what this captain was writing about, and I just so happened to look him up, Captain Adam Myers, and was fortunate enough to speak with him on the phone this week. After seeking help for an officer-involved shooting he was involved in, his agency let him go. He was sidelined for 4 years and no other agency would hire him. So he embodies resilience in every way. So it was a pleasure talking to him and to be able to share his story today. It's pretty awesome. Throughout my journey, my 6 years, especially in the past couple of years, I've taken over 100 hours of mental health and wellness training, and also in resiliency. Georgia Post now offers a resiliency training course for police that is 24 hours long. And this is a video that shows another officer's account of what some of the stress is like that she went through on the job. This training has been very helpful for her.
Let's see. It's us. Let's see if it'll work though. Let's see.
Welcome to the new generation of web creation, where words can launch a business.
Fire shooting, traffic accidents, domestic violence. Central Georgia law enforcement officers see it all.
But how does it affect them the next day and the day after that? Now, resiliency training is being offered to help law enforcement officers and others navigate tough times on the job. Jasmine Lee shares how the program helped one poor girl through her trauma. I gotta do all myself. I don't have enough of myself.
It's been 8 years in law enforcement, but Sharonda McIntosh says sometimes it still feels like her first day. She's a corporal at the Henry County Sheriff's Office.
We all deal with mental health, but if you don't treat it, it can always end bad.
That's why Georgia's Peace Officer Standards and Training Council started a resiliency training program. More than 1 year ago, they began offering the course for law enforcement to help them navigate these situations and to deal with the trauma. Georgia Public Safety Training Center began their training in March.
We have access to jail students, basic law enforcement students, 911 dispatchers, firefighters, and so it's more of a natural program for us to deliver.
Was where McIntosh went when things got to be too much, like after she found an inmate dead in his cell 1 year ago.
He was waiting, planning, so I flipped him over and started CPR. And I had, he was deceased, not his job. And I had anxiety and panic attack because I had bad health and I was trying to CPR and some of my coworkers froze, so I had did 5 rounds before somebody even thought to come help me.
During their career, police officers face an average of 178 traumatic experiences. That's according to a study published in the Journal of Traumatic Stress. And those stressful events multiply an officer's chance of developing post-traumatic stress disorder. The resiliency program aims to reduce that burden significantly. Kevin Angel is the public information officer for the Georgia Public Safety Training Center in Forsyth. He says resiliency training promotes health, well-being, and peace for officers. It's why they're requiring it for new hires.
But sometimes there's not a lot of time to deal with situation, so this gives those skills.
Nancy Greathouse manages the resilience program. She says students also work on telling their stories and focusing on communication skills with classmates.
We talk about mindfulness. That's one thing. And a lot of that technique is controlling your breathing. How do I get my mind off the incident just happened?
McIntosh says sometimes she questions if the job is worth it, but since taking the class, she's found an outlet she enjoys to help process the hard days, adult coloring books.
No, it's okay to go. No. We don't have to feel like we're robots and hurt. Yes, you gotta find this table, you gotta find somebody to talk to, you gotta clock out. I leave the job at the job. Program manager Nancy Greathouse says they are working to host the 24-hour program at least 3 times a week in their Forsyth complex. They're looking to bring the class to other parts of the state as well.
Training is fire fees and dealing with officer stress, the difficulties that we face on the job. The resiliency class was part of what inspired me to take more training in the areas of peer support and mental health, and it was a very much turning point in my career a couple of years ago when I took that class. Reality of law enforcement stress. These are some of the things behind the scenes that the officers don't ever talk about. Repeated trauma exposure, critical incidents, the shift work, the rotating schedule, the sleep disruption. You work 12 hours, you get home, spend 4 or 5 hours doing whatever, maybe try to find time to spend with your family, your friends. Next thing you know, it's time to get up and go to work the next day. And after a while, that really wears on you. Long hours, organizational stress. There's a lot that goes on behind the scenes that's beyond our control. And over time, all of this stuff builds, and it builds, and it builds. And that's when it's time to seek help. Why mental health matters. All of those things, after they build up for a while, have an impact on officer safety. You got all of that stuff going on in your background, you're not going to be able to perform your job effectively. It affects your relationship with your family, your friends. And good mental health improves performance out on the road and resilience. Healthier officers are better able to serve their communities better. So that's where peer support comes in. We're there to reduce the stigma of seeking help, provide support after critical incidents, connect officers with trained peers. A lot of times, officers are going to feel better talking to one of us because they feel like they could relate to us more than they could a therapist or clinician. No offense. But we're also a bridge to those clinicians and be there to offer professional help when there's things that we can't handle as peer counselors. We also have tools and resources available for grounding and coping. What peer support is and what it is not. We're there to offer assistance to folks. I think we're on the wrong slide. Like, somehow. There we go. Slide. I got it this time. All right. We offer confidential support. We have very strict rules in place. We can't repeat anything that's said to us as peer counselors. All participation is voluntary. We can't force anyone to come see us and talk to us. It's all strictly up to them. We are not therapists. We're not clinicians. We're not internal affairs. And we're not there to snitch on anybody. One of the things we offer is if there is a critical incident that occurs, we offer critical incident debriefings, and we have been very fortunate in the city of Powder Springs to have the assistance in a couple of hours lately by the Georgia Department of Public Safety Office of Peer Support, and as well as local peer counselors from surrounding agencies. They come in, and when officers are involved in a critical incident, we do debriefings. The discussions are very structured. They're led by trained peer members, and it helps process the trauma and reduce the long-term effects on the stress. Confidentiality. This is one of the things that I have found as a peer counselor that we struggle with. Trust is essential. Conversations are to remain confidential. And I've had officers, like I said, we're a new team in Powder Springs, and one of the big challenges I've had is getting folks to trust and talk to us. That's one of the things we face, because one guy said, I don't know if I want to talk to you guys or not. And I'm like, why? And he said, well, how do I know what says not going to leave that room? I tried explaining it to him, all the things that are in place to protect what is said, and it's still, that's one of the biggest things is trust. Trust is essential, and it's key in trying to establish those relationships with folks is a barrier that we're facing right now. Signs an officer may need support. I've seen all of these, and I personally lived all of these, and it's like I said, that's why I decided to become peer support, because I want to help other people not get to this point. Still think that you guys are seeing slides that I am not. My computer's off over here.
There you go.
All right. Once again, things to watch for, not only amongst your peers, but those who work underneath you. Withdrawal, mood changes, sleep disorders, sleep problems, job performance decline, excessive absence, sick days, or tardy. See any of those? It's a sign that an officer may need help. Barriers to seeking help. Police subcultures. I've always called that the tough guy syndrome. So many people just, they don't want to help, they don't want to talk to us. They're afraid that there's a stigma attached to it, and if they speak to us, it's going to show a sign of weakness. So they're afraid they'll be isolated from their peers. Peer career impact. Much like what happened to Captain Myers, officers are afraid to come forward. Confidentiality concerns. Like I said, I had an officer say that even though there's confidentiality in place, they're still not convinced that discussions will not be repeated. Tara asked me the other day, she was like, well, what do we do if they won't talk to us? I said, just be there to support them. That's all we can do. Stand in the gap. Benefits of peer support to a police department. It builds stronger morale, reduces burnout, improved retention, creates a healthier culture within the department, and increased productivity. Benefits to officers and their families. Emotional support, long-term wellness resources. We have available therapy, employee assistance programs, spiritual guidance, physical fitness, and wellness. So how do we go about implementing a peer support team? Select respected officers. Our department, in order to select the officers that are on our peer support team, we have to write a letter of interest. It's used for the selection of the officers that were chosen. Provide training. We went to a 40-hour course through the Georgia Department of Public Safety Office of Peer Support and became peer counselor certified. I have information here on how to get in touch with them if anybody's interested. Establish policies. Powder Springs is working towards implementing policy and procedures for our peer support team. We're still very new, so we got our certification back in October. And before we could ever get our policy written on how peer support is gonna go and how everything's gonna work, things started happening. So we had to start planning and taking care of critical incident debriefings before we could ever even get our policy written. So it's been extremely intense lately. Another key is partnering with clinicians. We have awesome people like the Nickel Center and other folks in our area in Cobb County that come and help with us, and they're always standing willing and ready to help us at any time we need them. So we sincerely appreciate all of their help. Leadership support. This is key. We're very fortunate at Powder Springs Police Department to have the best command staff that there is. They support us wholeheartedly, and that's a big key to peer support success. Supervisor encouragement. The gratitude that's been expressed from our supervision has been very welcome and appreciated, and wellness is a top priority at our agency. Commitment the Powder Springs Police Department has through our officers is commitment to our wellness, supporting those who serve our community. Other agencies have been invited to our critical incident debriefings, so we not only support the Powder Springs Police Department, we support the other agencies that have been involved in critical incidents in our area as well. Building a resilient department and ensuring that no officer has to face challenges alone. So how to start a peer support team? Georgia Department of Public Safety, as I said, offers a 40-hour peer support certification course. They provide statewide resources, training, and incident support. They've been tremendous in helping us. They coordinate the counselor training, and they support agencies by responding to traumatic incidents. We had a critical incident back in December, and I contacted the Office of Public Safety Support. The outpouring that we received as an agency was tremendous. They filled an entire room with peer counselors. They even had a dog there, therapy dog. It was unbelievable. So the support that we received from them and the training is second to none. Taking care of those who protect our communities. It's not optional. It's essential. It's okay to not be okay, and it's okay to talk about mental health. Anybody have any questions? Okay.
Oh, thank you for listening.
Can I say something real quick?
Yes.
First of all, great job on the pivots. Great job.
Even with technical meetings.
So originally, I was scheduled to give this presentation, and I knew the best person to do the presentation was Dr. Tibbetts. She has done a phenomenal job with our peer support program. Like she talked earlier, we've had several critical incidents, and she hit the ground running. She got resources together. Officer Tibbetts ordered me. I can talk about this incident. It was pretty hard incident for one of our some of our younger officers. We had a wide range of officers. My name is Officer C3R. I'm one of the patrol lieutenants. I oversee uniform patrol. I've been a police officer for 19 years. We didn't have this 10 years ago. We didn't have this 6, 7 years ago. So we're big in our department in Cobb County to give resiliency training, to give support to our officers. And at this particular incident, we had a double homicide. A family, husband and wife came home, and as they came home one Saturday evening from brunch, they were shot and killed by their stepson. And for one of our officers there, it was a pretty traumatic scene. But with peer support, it's not just the police officer that gets the support. It's the 911 dispatcher that takes the call. It's the paramedics that arrive on scene. It goes all the way to the top. And Officer Tibbetts, Sergeant Mee did a phenomenal job getting that resource together, getting everybody together, and just giving the help. Because we talk about it all the time, we're humans behind the dash. We deal with so much. Who do we talk to? Who do we talk to? And I can talk to y'all, the clinicians. We might, some of y'all.
There are heroes.
But peer support is a great program for those agencies that don't have it. It motivated me to become a peer support counselor. Now, I've been in law enforcement for 19 years. Now that job she did, a phenomenal job she did, and the team did, motivated a lot of our veteran wives. Hey, I want to get involved. So again, great job, Nickel Center. Thank you guys. They've come to our department a few times. We've had incidents with overdose. We had a newborn child overdose on fentanyl, and it affected our officers pretty bad because a lot of those officers that responded to that call were fathers, young fathers. And so, we always praise you guys coming out, supporting us. And we always appreciate the invitations. And we always, we'll reach out to y'all, call us, especially when it comes to critical incidents. I know I'm speaking a lot. I speak Spanish. So I might start talking Spanish a little bit. But I'm trying not to rant too much. But thank you guys. Thank you.
I can, what we want to thank you is we don't thank our first responders enough for what they do. And sometimes it is very easy for us to just see you as a police officer and not as a father or family member, or sometimes not. For you and all the other first responders in the room, I really believe.
Thank you.
I'm fortunate to have the command staff and the people that I have behind me, supporting me and supporting the other officers in our agency. It was awesome when we did our first critical incident debriefing. When we started out, when I started this journey a couple of years ago, I never thought that my main focus in law enforcement would become the wellness of other officers. I never saw that coming. And it's like I said, life happened, and that's what inspired me to do that. So last year, at this time, I was sitting fall sick, and I couldn't be at this conference, and that was very, very disappointing. And during that time, I had a lot of time, like I said, to reflect on what I really wanted to do with my career and the things that were important in perspective. So I didn't get to go to this conference, but there was another conference that came up in Marietta. And this will tell a story about how far our agency has come and give praise to our command staff, and that is key in peer support. That's key to all first responders is the people that they have above them. So I wanted to go to this conference so bad. And so I applied and training at night. I was sent a letter and said, explain why or how that this conference is gonna benefit our agency. So it took a little convincing and a little day one, but I managed to be able to go to this conference. Fast forward to a year later. Now, same person, that none of that training. This is not about me. This is hoping to inspire you all to be a voice of change. It's not about me. This same person now introduces me as being from the peer support team, police department, and wants to know how he can help. So I encourage you all to be a voice of change within your agency. And it's amazing to now have the support of folks like the Nickel Center, command staff, our assistant city manager, Ms. Phyllis Callaway, our HR lady, Ms. Roslyn, Lieutenant Cipriano, and all the clinicians in the room. I thank you all. And I hope to encourage you all to be a voice of change within your community. Thank you all so much for this.
All right, everybody, we're gonna take about a 10-minute break. Right?
About 7 minutes.
7-minute break. 7-minute break.
Because they're gonna try to escape, so.
Oh yeah, that's
Yeah,
true.
you know, so
7 minutes. Yes, you are good to go. Yes.
We're almost done.
Oh, here you. Here's your split.
Thank you. Awesome. Yeah. It's gonna be. I'm trying to have every single. It's never leaving my head. It's going to like. Oh, I'm big. I'm here out like. What we could do with and I'll see us. Right. Well, the sun, she bullshit. Well, I don't find her. That day, that was, I can show you. You got so glad. I'm like, you put the human to it. You did.
Hey, can I put this on you?
Oh, we
Yes,
need a
so we
mic.
can hear you. Yeah, we'll be able to hear you from the one.
I'm not gonna be up
Where are you going? Oh, we'll hear them. We'll hear them. Yeah, for the video. Yeah.
So we ready? All right, here we are at the 11th hour, and they put me on stage. Okay, so we're not gonna keep y'all long. That is me, the first one, but I am the second. Kenneth, most people know me as Scooter, sober Scooter, Reddick the second. Okay, I wear many hats around here. My first hat is I'm a husband, a father, and I'm a servant leader in the community. I have the Brothers Brunch Foundation, which is not a time to eat, but be fed mental health and self-care training. So many of y'all may have seen my information out there at the first table. I just hadn't been there today because first I had to go to Lithia Springs and do some work over there, talking to the students, and they had to stop by factory shows. And then I had to fulfill my obligation here with the Nickel Center, where actually every Thursday morning I lead the men's support group for the Nickel Center. That's where Tara and I have been in partnership for the past 3 years since the beginning of the Brothers Brunch Foundation. And actually, before I came certified peer specialist and working in her center and those sorts of things, she was my community partner award winner from my first living ball for Brothers Brunch Foundation. So we have a very great relationship because we both truly care about the community. And I would imagine that's why each of you all are here today, because you truly care about the people in our communities. One of the things that we are going to talk about is some of the risks and some of those supportive measures that we're able to take in many of our settings. For me, one of the things I'm big on is that mental health is not a diagnosis. I say that because so many times in our communities, when we say mental health, the first thing people say is, nothing's wrong with me. And say there was anything wrong with you. You're talking about mental health the same way we talk about our physical health. So with that being said, one of the biggest risk factors that I focus on with the men's group is focusing heavy on our mental health, not just our mental health challenges, which is truly something that we do at the Nickel Center, but also we have to do more of in the community because the biggest risk is not being proactive. I tell people it's like working out in the gym. Somebody, if your partner come to get a hold of you, you're going to be able to shake him off if you've been working out, right? But if you haven't been working out, he's going to get a hold of you. You're going to be saying, let me go, this and that, whatever. It's the same way with our mental health. So the biggest risk for our mental health challenges is not taking care of our mental health. So that is where we have resources and we have groups and we have conversation. Yeah, I wear hats as a certified peer specialist for parents, certified peer specialist for mental health in general. And then even from a whole health action management perspective, making sure that that wellness component is in so that our spirit, mind, and body can be the best it can be to protect our mental health. So I think that that's one of the things that we have to look at in the work that we do, especially from my angle in the work that I do throughout the community is I want to protect our mental health at whatever cost. Because I know somebody said, and she had mentioned about that it's okay to not be okay. One thing I say is it's okay to not be your okay. Because when I start taking care of my mental health and being proactive, then I know what my okay is, and there's less risk factors. The other thing I just wanted to share with you all is that on Friday, I turned 52 years old. But I woke up that morning and I looked on my phone and there was an app called Lucid. Anybody know what the Lucid app is? It's a sobriety tracker. And it said on my 52nd birthday, I was 1,500 days sober.
So that was the celebration and a blessing for me to always say that when I turned 52, I was 1,500 days sober. But why do I say that? Because I was a 25-year executive territory platinum performer sales representative suffering in silence for all of those years. But on top of that, I'm a 3-time suicide survivor. Which if any of you all notice on my table, I have a 988 flyer with my picture on there. I didn't have my picture, and once I was taking them to all the barbershops, one of the barbers said, you need to put your face on there so that people can relate to what's really happening. And I did just that. So one last thing that I do that is not necessarily a part of the Nichols Center, but it's a passion, it's around suicide awareness and suicide prevention. Anyone in here ever heard of QPR? Okay, all right. What is QPR? Somebody yell it out. Not you. Question, persuade, and refer. Okay, no problem, no problem. Good shot, good shot. You might get a prize for that. You know, this and that. But question, persuade, and refer. That is a training that I've probably gone through or sat in at least 4 or 5 classes. And it's always good to hear the thoughts that people have of the lack of understanding that we have, because first and foremost, we're afraid to ask someone if they're going to unalive themselves. Or are you thinking about killing yourself? That's the first part about that question, becoming feeling comfortable so that anyone in this room, regardless if you're a clinician or first responder, we can all save lives just by understanding. I had one person of all the times when I was thinking about unaliving myself that actually said, Scooter, I actually think that you have a plan and you might do it. And that just took me aback to know that I had somebody that cared enough to at least tell me that. Because everybody else was probably scared to, but they didn't know that still had me feeling alone. So I talk about this training also not because been through it a few times, but because now I am certified to instruct that class, to certify others. So one of the reasons why Tara wanted me to be on the stage too is to let you all know that if anyone knows any organization that may need some support, that wants to certify all their people in the organization, if the school that wants to try to certify some parents or whatever it may be, please reach out to me. Because I can be there. We can work something out, whatever we may need to do, because I know what I didn't have. And the reason why I do what I do, when we were back then, y'all heard me say, well, why do you do this? Because it's my purpose. I realized that this is my purpose and I have to walk it every day. And if you notice, I didn't say I help people. I don't have an answer for them. I can't fix it. I support them. Meet them where they are. The men in my group, I meet them where they are. I shift the words. No, we're not going to say we can't. We have to make sure that we manifest those things. Y'all heard me say spirit, mind, body. Everybody else say mind, body, spirit. And get out my mind. Put the spirit first. And understand that as I'm walking in purpose, it eases my mind, it eases my mental health. And therefore, I'm able to make the appropriate actions with my body. So, that's my story, and I'm sticking to it. All right. So, any questions for me about anything before I pass it on to my other colleague here, and she will tell. Are we going to edit first? Okay. All right. Then we're gonna go to Miss Kelly, and she'll tell you more about her roles and things at the Nichols Center. So, I thank you for listening to me for now.
Hey, so my name is Kelly Keys, and I'm a person in long-term recovery. And what that means for me is it's been since December 5th of 2019 since I had anything to change the way I feel or think. I'm a person who was incarcerated, a person who overdosed, very lengthy 26-year story. But more importantly, today I get to stand up here and I get to tell y'all about risk factors and protective factors. So I want to tell you the difference. So a risk factor is our fears. There are fears of stigma, a lack of knowledge. And the protective factors are connection awareness and people willing to step in. A couple of weeks ago, I was at a dinner with a bunch of recovery friends. And while we're sitting at the table, one of the recovery friends gets a phone call and a girl's frantic on the phone and she says, there's a girl overdosing and I don't know what to do. Well, I do know what to do because I was that girl that overdosed one day, you know, and because I come to things like this. So the guy that was on the phone, he didn't really, he was hesitant in giving her, you know, what to do. So I asked to take the phone from him and I got on the phone with her and I said, look, you have rights under the amnesty law, which is the Good Samaritan. You can call the cops. You're going to be okay. It does not matter if you have done drugs. And I explained to her, get rid of them. Just get rid of them and then call. She was still scared. I said, okay, let's do it together. Now that is called peer support. Peer support is when we can hold somebody's hand and they trust us because they know that we've been there, that we understand their fear. So with that being said, I gained trust with her and I said, okay, we're going to call together. So I phoned in 911 on the call with us. And while they was coming there, I was going to her and I was letting her know, I'm coming to you. It's going to be okay. I'm going to be there when they get there too. And the girl lived. I was also telling her about how to administer Narcan. She did not know how many times you could administer Narcan. So I was able to tell her that it did not matter how many times. So the girl that was overdosing, like I said, she lived and a life was saved. Without the knowledge of the Good Samaritan's law, people will die. In order to save a life, you have to educate people. And it's really important for us to tell every single person we come in contact with to let everyone know because we can save a life. So I'm sorry, I'm not, you know, God in person. I don't have the things that there, so I got to maybe look at my paper. So I just want to say the tools are during overdose, put protections in place. People are very afraid. Teach them to call. Stand in rooms where, you know, I've heard a lot of like drug courts and stuff like that. Even if you're a person that you have a person who's going through a drug court or they're coming through counseling, they look like they're doing the right thing because addiction is a disease. We have setbacks, and that's the reality in it. If you're in contact with a person, even if you think we're doing good, tell us about this Good Samaritan law because it can save a life if we ever was to have a setback. And we know people, we're like this big network and we advocate and we stand in those rooms. And that's the importance of peer support is that we have a voice that some of the other people don't. So, and this is my friend Eddie.
I'm Eddie with the Nickel Center. I'm working in long-term recovery. I've been working my recovery for 4 years now. For 30 years. After 30 years of substance abuse disorder, it was a life that until I was first participant of, and first we were 5 accepted into felony drug court here in Douglas County. I grew up here in Douglas County. When I moved to Douglas County, I 20 ended. I was 5. That tells you how long I grew, you know, being in Douglas County. Um, most of that time I was a popular guy. I knew everybody. You know, everybody from the homeless and I was wild. And grew up, got in a lot of trouble and had a lot of life experience. It wasn't until 18 to 20 months ago that all that changed. While in drug court, I was able to get the GED. After drug court, I was able to get the CDLs. I was able to live my childhood dream of being a truck driver. During that time, I found out being wasn't what it was when I was a kid. When I was a little kid, used to go with my uncle on trips to California. I loved it. Wanted to do it. That's all I wanted to do. Was being in drugs. And that was something that wasn't going to happen. Well, give me that. But now it's accountability. Being the first group of 4 to graduate. I did the truck driving thing, and even in the trucking industry, drug use is rampant. I've sat in the fuel aisles and watched people shoot up to death. I have, familiar with this. I'm sure everybody in the room knows what this is Narcan, the lifestyle. Everyone in this room should have this in your glove box. You never know when you're gonna need it. Most people, when they hear of overdose, most people's stigma is someone with substance abuse. Lieutenant stated earlier, they dealt with an infant, and that can happen. You should have this in your glove box. You should have a box of it on top of your refrigerator. You may not have a problem. You never know if your friend comes over. Say you had hip surgery. Your pain meds are sitting on your nightstand because you don't have kids. You don't have anybody. Your friend comes over, y'all talking, catching up. Little Bobby, and she'll tell you, little Bobby gets into stuff, and all little Bobby's off playing. Little Bobby's kind of quiet. You go find him, and he's got to do your pills, taking their skips. Now you know, this is not a cure. This is just buys you time. It buys you time because when you call 911, they don't drop down out of the sky. It takes time to get there. It buys you time for them to get there. Make sure there's the drugs now, some of the drugs now, for resistant. So it takes a lot of this. What brought me before y'all today was 18 to 20 months ago, I was involved in a fatality accident. I had to make 4 life decisions, drink and drive, pulled out in front of my semi, and it knocked me in my career. Death. Injured me. I didn't realize then my higher power put me on my front porch for that 18 months. Took me to some dark places. Christian notice, but it also made me realize he told me, give you all these life experiences, things, and I've got some parts from all the person. Give you these life experiences in order for you to go out and you need to go out safely. I have power. But I was like, how? Nicholson has been a part of my life for 12 of those 13 years. Always hung out in the back shadows, kind of did events and stuff. And so that's how you're going to do it. For the Nixons, you're going to talk about something. You're going to tell them, get Narcan, carry Narcan with you. I've had to administer as a truck driver on the road, had to administer Narcan. 2 different times, 2 different people in the same McDonald's. You never know when you're going to run up over another. Not too long ago, I live out on the other side of Covington. When I say out of the side of Covington, 20 miles the other side of Covington. Got to the Nickel Center every morning. And I'm there at 7 o'clock every morning. Be there for anybody that walks through that door, no matter what their crisis is. I teach anger management in the experience. Help facilitate the ministers, the scooter here. Recovery support, peer support. Anybody that walks through that door, I'm there for one time. Yeah, if you get a little nervous because it's new to me. Thank you for y'all's time. Like I said, fill out the survey, get you a box. Just put this in your glove box. You never know when you're going to walk into the crazy factory or into my case, into a McDonald's or into Walmart. Someone in Covington passed away a couple weeks ago. My niece passed away. Heart cancer. She took a Xanax. This was just 2 months ago. Took Xanax thinking, she long story line, and she didn't get the cheer squad, and so she was devastated. Her friend gave her a pill. I was like, it upset me because I had preached to her, don't take anything unless the doctor physically said, if you're not getting it from the pharmacy, don't take it. I don't care if it's ibuprofen. I was a true believer in it. Like I say, I've seen it save lives. I'm sure, are y'all all have me in the room aware of those kind of spots out of it? Dilate pupils, lose the lift, shadow breathing, unconscious, won't wake up. Instant is not it don't go bad. You put it in the glove box, won't go bad. If it's not an overdose, it's not gonna hurt anybody. Bad, you got to save a life. I've seen it. That's a little bit of my story. I'm sure y'all have seen me, and some of y'all have seen me before. I've met the lieutenant before. Remember a couple other things, and I'll fine tune my story a little. I'm the one that guy, you get up here and wing it. Another thing I fix is that I have 8 minutes. I have 8 minutes to one of our mini campaigns, stop by the desk at me, see things, 8 minutes can change someone's life. When people ask me, because I get asked a lot about, what's that 8 minutes? You take 8 minutes statistically to talk to somebody out that ledge. And that ledge could be just that, except the ledge to jump off of the building, the ledge to stick a needle in their arm, that ledge could be a mental health episode that could save their life or someone else's life. Actually had someone with a mental health episode kick a door in. That is me and 2 other people were sitting on the couch and he shot female, which was his wife, not the male, which was his brother. Looked at me and said, you didn't have nothing to do with it. And I walked out, over shot and said, someone could talk him before realized what he was about to do and stop and took his statements, stop him. Maybe he wouldn't have done that. It would have been 3 lives. Had I known, I mean, I didn't know till the door came. Some of the life experiences in the drug world that I experienced that I didn't know at the time, him putting me through situations that he knew that I could handle, but not share those stories later in life. Being someone in recovery, that Kelly had mentioned earlier, people are more receptive to somebody like us, like when law enforcement talks about, they will talk about their situations. They started their career, but it works the same way in the youth world. People, the biggest influence for me in sober was hearing from other people, people in order sheets, all the ministry. I listen to them and I have touched more lives that way. People tell me I've been inspired by you because how long you've been, if you can do it, I can do it. I've had people from the sheriff's department come keep checks first thing you're winning. I just like give people hope, again, if I can do it, they can do it. Don't mean that, but no way.
I just want to step in and tell y'all one thing. I talked about the fear that these people are experiencing, during overdoses and not knowing about this Good Samaritan law. But I want to tell you something that may help you understand how important it is. I told you I was in an addiction for 26 years. I've got 6 years in recovery. When you match that, that's not, I still look in the rear view when a cop gets behind me, freaking out, anxiety, panicking. When I told man, this man right here, I had to go introduce myself so I wasn't scared. First thing I did was walk right up to that table. but that's just because that fear is embedded in us. So we're not, the individual is not going to not give the person the call to the ambulance and get them scared. They're literally scared. It's an overwhelming fear. So if we take that fear away and we tell them it's okay, and they're not, I sat there and debated that law for the longest time until a cop told me it was true. I had to hear the cop tell me. And I say that because it's important that people in the higher up positions are the ones that are telling these people how important this Good Samaritan law is. Because I can tell them about it, but they're going to research it probably. But with that also being said, the kids are important too, like reaching the kids. At the Nickel Center, I work with the workforce program, and on the workforce program, we're helping these kids get, education, and this program's amazing. We talk about suicide. I have a son that's actually in that workforce program. He's 17 years old. He dropped out of Douglas County High School, and he was suicidal every other day. I was afraid I was going to come home and find him. This workforce program, the programs that we create, that all of this room creates, are saving lives. We just have to make sure we tell the right people. Thank God.
Cohort. That is a type of, that is the name of a program that does that, but it's not what I'm thinking of. It's the type, what do they call that branch of programming? We talked about it. When did we talk about this? We talked about this in the morning section before we talked about how mobile integrated health is a type of this program. It's all under this branch of program. C3R, that's the name of our collaborative.
Co-response?
Yes, co-response, or also called alternative response. It's been a long day. You guys have had a lot of information. She's like, I get these prizes available to me in the option.
No, I don't know.
All right. Let's see. What else? Tell me, you guys keep saying C3R. What is C3R? And you know the definition of what we call
Get a nice little warm blanket.
Come on. Wait, they're looking at the question. The guys up here. Not the belt. Belt's mine.
Oh, that's one of our trees.
It's again one that's got race to resiliency. It's gonna be that type of yeah, what kind what do we call response? Exactly. What does it stand for? Community. Community. Collaborative. For crisis. Response. Here you go. I hear it from. Thank you. Response. They get your prize. Put my hair back in. They were coaching in it. All right. Let's see what else. We'll give you another. Okay. What are the signs of opioid overdose? Give me three signs of opioid overdose. Unconscious. Dialect people. What? Clueless. Come get a prize. Get a prize. Come on, don't be shy now. All right. What else? What does MIH stand for? What does it stand for? Multiple health and get prize. All right. Let's see. Welcome prize. Nobody else? Think of another question. Trish wants another good question. So Ebony talked about trauma informed, being knowledgeable of trauma, but what was the added application of that? Ebony Phillips talked about being trauma informed, which is the knowledge of trauma, something that could be traumatic. Oh, what you already got a prize. What's the key word? What was the application of that trauma informed approach? Trauma response. You got a prize? Yeah. We're trying to be inclusive here. Okay, and ask that. Oh, what is Linda's favorite word of all time?
Inclusiveness.
All right. What's something you learned today?
Therapeutic
Jurisprudence. Excellent. All right, who else is not gotten for us? Hey. I'm able. Okay, so after you present, I'll ask you questions about your presentation, and then you can get a prize. Our next speakers, we have some great long-term friends of mine, Miss Renee Smith and Nikki Sanders. Sorry, we can think from Facebook. So Nikki and Renee are co-responders in Carroll County. Nikki works with the Sheriff's Office of Carroll County. Renee works as part of the Georgia Mental Health. No, that's something else.
We both work.
Carroll County Sheriff's Office. The Sheriff's Office, but you also work closely with the Carroll County advocates. They're long-term friends of mine, amazing ladies. Please give them a welcome. And they're going to come to class today.
We're going to the podium.
Going to the podium.
Sorry. It's not Sean. Okay, so I'm super nervous. I don't like doing this, but I'm here. So as she said, my name is Renee, and I work with the Carroll County Sheriff's Office on the Behavioral Crisis Unit. But more importantly, I'm a person in long-term recovery. This January, I celebrated 9 years in recovery.
Congratulations.
So I show up supporting individuals experiencing mental health emergencies, substance use issues, and suicidal crises, both in the community and in collaboration with law enforcement. That has gave me a newfound respect for law enforcement, because a month after I started working there, we had one of our deputies died. He got shot. The guy was trying to shoot himself. He shot himself. He committed suicide. But when he fired the gun and shot himself, it shot out and went to the other guy, one of our deputies, our investigators' head. So that was like, and then I started talking to them about peer support inside our office, which I've been there almost 2 years and it hasn't happened yet. So yeah,
We were getting some coffee.
So my role puts me face to face with people on some of the hardest days of their life, when they're overwhelmed, out of options, and just trying to make it through that moment. That's why meeting them where they're at is very important. Through this work and through my own personal experiences with recovery, I've gained a deeper understanding of what crisis really looks like, and more importantly, what actually helps. In the U.S., suicide is one of the leading causes of death, and millions of adults experience suicidal thoughts each year. About 1 in 5 adults experience a mental health condition annually. This isn't rare. It's something we're seeing every day across communities, and it's not just, it's every day with everybody. Like, if you have anxiety, that's a mental health condition. You know what I'm saying? I consider what I have a lot of times is, I call it situational depression, which it sucks. So I work in the crisis, and one thing I've learned quickly is that people don't show up at their worst because they want to. They show up because they don't know another way to survive what they're feeling. A crisis isn't always loud. It's not always dramatic. Sometimes it's quiet. Sometimes it looks like shutting down, using substances to cope, or having thoughts that feel too heavy to carry alone, whether it's mental health, suicide, or substance use. Especially opioid overdose, the common thread is the same: overwhelmed with no coping left. A lot of what we see in crisis is misunderstood. People label it as an attention seeking, which I've heard that before. I've heard people talk about it with my family members. Manipulative and non-compliant. What I've seen over and over again is that it's not attention seeking, it's pain seeking relief. When someone is in crisis, they're not thinking about long-term consequences. They're thinking about how to make the feeling stop. For a lot of people, substances become a way to cope with what feels unbearable. Which is what I did a lot of times. I was self-medicating for a long time, from domestic violence, from a marriage I was in with my teenager's dad. I went through that. It's a lot of trauma for me that I've overcome, thank God. It's not always about wanting to get high. It's about wanting relief. Relief from anxiety, depression, trauma, or thoughts that won't slow down. In those moments, substances can feel like the only thing that works fast enough, but what starts as coping can quickly become another layer of crisis. Especially when it comes to opioids, we're not just talking about use, we're talking about the risk of overdose, sometimes without warning. And a lot of people we see didn't set out to become dependent. They were trying to manage pain, whether physical or emotion, and it escalated. Because a lot of times people get prescribed pain medicine and it just escalates. They can't get a doctor to prescribe it anymore. So then they just go out and they get heroin or fentanyl or whatever's cheapest, and the high lasts longer. Over 100,000 people in the U.S. die from drug overdoses each year, and it's probably went up from that, with the majority involving opioids and xylazine, and God knows what else is out there right now, because now I'm seeing there's 2 and 3 different things that's done popped up just within the past couple of weeks.
when we talk about substance use in crisis, we're also talking about life or death risk. So when we respond to substance use in crisis, it's important that we don't lead with judgment. Because if we only see the substance, we miss the reason behind it. And if we miss the reason, we miss the person. And I don't just understand this professionally, I understand it personally through my own recovery and my own struggles and some of those that are closest to me also. Even like with my own child, he's 19 and he struggles with substances from trauma that he doesn't want to seek help for because he doesn't think there's anything wrong with what he's doing. I remember what it felt like to be in a place where everything in my head was loud, overwhelming, and nonstop, where coping didn't feel like an option. And I was just trying to get through the moment however I could. In those moments, what helped me wasn't someone trying to fix everything at once. It wasn't a perfect plan or the right words. It was someone showing up, staying calm, and reminding me, even without saying it directly, that I wasn't alone in that moment. So I'm gonna pause right there and talk about something that recently happened to me. That thank God I have Nikki. She's my best friend. On March 3rd of this year, I lost the guy that I planned on marrying and all that to I want to say alcoholism because he drowned himself in alcohol because a lot of people don't think alcohol is an issue. They think that it's so accepted by society that even with law enforcement, I hear so many law enforcement officers talking about, I promise you that just about everyone will go home and drink at night. Whether it's a couple of shots to just ease the stress for the day, that's the deputy that did work with me. That's what he used to tell me. But he passed away from the damage that he did to his liver and his kidneys, which caused him to go into cardiac arrest. Well, he was 36 years old, you know. And the other day, which was what, a couple days ago, I think I don't know. She said it's okay to spiral, and I didn't feel like that's what I was doing, but that's really what I was doing because I just left work because even on the days that it happened, I still showed up to work. I went in, I talked to the guys in the jail because I do that. I work on the outside, she works on the inside of the jail. But I still show up and I let them know that like emotions are real. Like what we go through is real. Even myself, I go through things no matter how long I've been in recovery, no matter how long I've been going through anything, how good it looks, I still go through things. So that's very hard. It's still very fresh, but I thank God that she was like, it's okay to not be okay because when we're going through those things, we don't take that time to stop and think, oh my God, like I'm really going through something. And it is okay for me not to be okay right now. She helped me a lot that day. I didn't tell her that, but I am now. She's great. She's great utilizing, we're both CPS and mental health, which is certified peer specialist, mental health, addictive disease. I'm a CPS parent because my kids going through trauma from being in foster care, forensic peer mentors. We're all of the things that you can possibly get to help people in mental health or substance use. We're all things recovery and mental health. We try to go to every conference, every training that we can, because the more that we know, the more that we can help people. So just by her showing up and reminding me that I wasn't alone in that moment, even as I was sitting at the cemetery that day, it mattered to me. And I think it really helped me more than I realized because since that day, I have somehow found some kind of peace in what happened with him. It's so crazy, y'all. I don't mean to just ramble on, but even just this week, I got a referral for someone that I'd been dealing with for a year that was found unconscious in his truck, and there was a half bottle of vodka in it that he had drank. So it's almost like just so many things that like it's insane, like what God does sometimes. And it's like you really have jokes right now because I just dealt with this March 3rd and now it's like March 10th and you've got this guy that I've been trying to deal with and he was in ICU this week, but he lived, so he's living and he's gonna be fine. Maybe. So that experience with her, it helped me find some peace. But what helps in crisis isn't control, it's connection. And we always say that the opposite of addiction or even mental health things is connection. Before resources, before referrals, before problem solving, people need to feel seen, heard, and safe. You can have every tool available, but if a person doesn't feel understood, none of it will land. And of course, it's not going to help. In crisis work, tone matters, presence matters, meeting people where they are matters. It's not about forcing change in that moment, it's about helping someone survive it. Crisis units and first responders are encountering mental health and substance related emergencies at increasing rates. This is something many of us in this room are seeing more and more, and it's not slowing down. When we approach people with empathy instead of judgment, we create space for them to come back down from that heightened sense, and that's where real support can begin. At the end of the day, crisis work isn't about fixing people, it's about sitting with them in a moment that they thought they couldn't get through and helping them realize that they can. And I'm going to talk about the mental health advocates real quick. So that's one of the best. It's Carroll County Mental Health Advocates and the Recovery Squad West Georgia. That's our recovery community organization out there. And that's one of the partnerships that I'm really glad that I have because my office is upstairs and they're downstairs. So I work really, really close with them, and she does also. Through the crisis team and the work that they do with Nikki as a forensic peer mentor, we've all been able to connect individuals not only to immediate support, but to ongoing recovery resources in the community. I'm not going to take her shine away from her, but she leads a second chance project inside the jail, and that's been really impactful as how the work continues even after they're released. Through the Recovery Spots program, Second Chance Project Beyond the Gates, participants are able to stay on the same curriculum outside the jail and work towards graduation. That continuity helps reduce recidivism and increases long-term recovery stability, accountability, and successful reintegration back into the community. In addition, the crisis team works closely with peer support teams to ensure that when someone is stabilized, they're not left without support. Instead, they're connected to people who understand recovery and can walk alongside them. That kind of collaboration is what truly strengthens our community and creates real opportunities for change. I think that's all I have.
Well, I was surprised. She usually flies through everything, and she's doing it. She's so nervous. My name's Nikki Sanders. I'm a person in long-term recovery. I just want to say thank you to the Nichols Center and Ms. Tara for having us today. I enjoy coming to this and learning. Like Renee said, we like going to anything we can go to learn more, to help more people. It truly means a lot to be standing in a room like this and share what I get to do, but also who I am and why I do it. Because for me, this isn't just a job, this is personal. I'm someone with over 18 years of lived experience in addiction and incarceration. I know what it feels like to be stuck, to feel like there's no way out, and I know what it feels like to make decisions you regret and to carry the weight of those decisions. And when I walk into the jail, I'm not walking in as someone who has it all together. I'm walking in as someone who used to sit on the other side of that door. And that changes everything, because I'm not talking at them, I'm talking to them. Today, I work with the Carroll County Sheriff's Office inside the jail, and I serve as a certified peer specialist in addictive diseases and mental health, as well as a forensic peer mentor. I want to stop and really recognize, like, I'm still on parole with an active GDC number, and I still get to go inside the jail and have a badge. With a swipe of the card, I can go in and out, where I used to could only walk the halls with handcuffs and shackles on. I get to bring hope to the hopeless and light in the dark. But more than titles, what I really do is this: I meet people where they are. On some of their worst days, when they're detoxing, when they're struggling mentally, when they feel forgotten, or they feel like nobody cares, or like they've made the biggest mistake of their life. I get to be there in those moments. I try to be someone who reminds them, you're not done yet. A big part of my role is connecting people to treatment, helping facilitate mental health services with DBHDD, and making sure they don't fall through the cracks. But the most important thing I do is build trust. Because when someone realizes you've lived it too, something shifts. For the first time, they start to believe that maybe change is possible for them. I also facilitate the reentry program there. We call it the Second Chance program. And in that class, we don't just talk about recovery, we talk about real life. Because getting out is one thing, but staying out takes a whole different set of tools. We talk about mental health, we talk about coping skills, what to do when life gets hard instead of going back to those old habits. We talk about triggers and stress and how to handle pressure without self-destructing. We talk about healthy boundaries because a lot of people are going back to the same environment and the same people in the same situations. And if nothing changes, then nothing changes. So we help them learn how to say no, how to protect their peace, and how to make different decisions. Even when it's hard, we talk about job readiness. We do interview skills, how to show up for those interviews, how to communicate, and how to present yourself. Because getting a job is one thing, but keeping it's another. We talk about family reunification. Most people think they can just get out and be mom or dad, but there's trauma there, and the caregivers that have been taking care of them don't want to just give them back. So we talk about what that looks like and how to repair those relationships that we've damaged. We talk about real roadblocks because reentry is not easy. It's not just get out there and do better. It's how do you stay sober when life hits? How do you handle rejection? And how do you deal with stress without going back? How do you stay focused when everything around you is pulling you backwards? We even talk about budgeting and responsibility too. But even more than anything, we're helping people change the way they think and respond to life. One of the most important parts of what we do is making sure people don't just leave with information, that they leave with connections. Like Renee said, the opposite of addiction is connection. Because getting out without support is one of the biggest reasons people end up coming back. That's why the collaborations we have are so important. We work closely with the recovery spot and with Renee at the behavioral crisis unit. Renee told y'all about the second chance beyond the gates. We've actually even had it to where we've gotten 2 so far and 1 on the way to having an alternative sentencing to complete the second chance project beyond the gates. Because the program doesn't just stop at the jail door. Participants don't just complete a class and walk out hoping for the best. They leave already connected, already supported, and already plugged into services on the outside. They're given a real opportunity to do something different, to engage in recovery and to build life skills, to start changing their future because we build relationships with them while they're still inside. So when they walk out the doors, they're not starting from zero. They already know someone. They already have a place to go. They already have support and that connection. That follow through, that's what changes the outcomes. Because for many people, the cycle looks like this: jail, release, relapse, back to jail. Over and over again. And the goal isn't just to manage that cycle. The goal is to break it. And that starts by helping people see themselves differently. Because if someone believes they're just an inmate, if they believe they're just an addict, if they believe they're too far gone, then nothing changes. But when they start to see that they are more than their past, that they still have value and purpose, that's when change becomes possible. I always tell them, if it's possible for me, it's possible for you. Because I'm not standing here because I did everything right. I'm standing here because someone gave me a chance. Because someone believed in me when I didn't believe in myself. And now I get to be that person for someone else. The work's not always easy. I heard someone earlier say it's that heart work. And that heart work is really hard sometimes. There's hard days, and there are days when people don't make it. And there's days when you see someone come back and it breaks your heart. There's ones when you work so hard to get them into treatment and they leave, and then they want to blame you because you put them in the wrong place. But there are also victories. Sometimes success just looks like showing up, asking for help, making one better decision, and sometimes success is not coming back. At the end of the day, what I do inside the jail is simple. I try to help people see that their life is not over. I help them build tools that they were never given. I help them prepare for a life that may have never believed was possible. And I remind them that they deserve a second chance. And I truly believe that because I've lived it. I see it every day, and I know change is possible. And I'll leave you with this: I just don't work inside the jail. I work to make sure people don't have to come back. Thank you. Oh, any questions?
Don't have any questions? Thanks. So that was called their program is a co-response program, right? Responding alongside response. Whereas MIA is an alternative response, long response. Right? Once we request that. All right. So what do you guys think? With our third annual educational summit, spring summit, Race to Resiliency. How many of you were excited about the idea of racing towards resilience? All right. So I hope you guys saw Christian today and put your name down for wanting more educational information packets and making sure that we're standing up with C3R in every community. And then let's continue this conversation. We're going to be building out. How many of you have downloaded our app? Okay. You're going to want to download our app or go to our website and actually become a member on the website. Okay, when you become a member on the website, you get access to key groups and pages specifically relating to these different interest groups and topics. So you can be a part of our volunteer group, you can be part of the C3R group, you can be part of the clinical cohort group. If you're a clinician, you want more, be part of our clinical cohort and access more free trainings. We have a separate group for that so that you're getting specific catered information. So you're gonna wanna make sure you're a member on our website and then request access to the groups that you want to be interested in. If you want to race towards resiliency, you're going to want to be in that C3R group, in that resilient response group, so we can start communicating and disseminating information and start collecting those incentive points for your community and walking you through that structure. So please make sure you've done that. Please stay connected and communicate with us. This is a big project. And I like to say there's no extra people in the board. No extra. You're all needed. Every single person in this room is needed, even the people that left early. Even the people that left early, they're needed. Everybody that came here today is needed in this fight. There's not enough of us. The good people, we still outnumber the bad stuff, right? So let's stay connected. Let's keep this conversation going. The next summit's going to be this fall. We're going to be looking for a place, a community to host that summit. Last year we did this at Powder Springs, not Powder Springs, we did this at Paulding County, at the Greystone building in Paulding County. But we're going to be looking for another partner community to host the fall summit. So if that sounds like something you and your community want to do, let us know. And we can talk about the logistics of that. All right? Everybody got a giveaway? Who didn't get a giveaway? Who wants a giveaway? Renee wants a giveaway. Renee, what you want for your community? You want a mug? You want a box of Narcan? You want a coloring book? You want a jacket. I know you want a jacket. Yeah. She wants a jacket. I have 8 boxes of Narcan in my car. Oh, that's good. Well, you never know. You can. There's other jackets out there too. If you want to switch it out, there you go. All right. I'm going to give the first installment of our 3 posters and our magnet board to Powder Springs Law Enforcement. Put up at their office. You get all 3 posters, 1 magnet. So you got 3 months of content right here. Thank you, Powder Springs. All right, guys. I hope you have an amazing day. Please make sure that you have written your licensing number or OT number by your sign sheet with your name. Make sure that that's up there. If not, we'll still send you a certificate. I just won't be able to submit your information to your respective board. So if you are licensed to the particular board, I'm going to need that to let your board know. Okay? You guys are amazing. We love you. Stay connected. Let's keep the conversation going. Have a great day. Thank you. That's better.